So good morning, everybody. I welcome you all on behalf of Rajasthan Orthopeadic Surgeons Association for this great academic feast, midterm ROSACON. Today, for the inaugural ceremony, we have President ROSA, Dr. Rajesh Goyal, sir, Chief Guest or esteemed IOA President, Dr. R.C. Meena, sir. We have two guests of honor, President-elect IOA, Dr. B. Shivashankar, sir. Another guest of honor, the Honorary Secretary IOA, Dr. Atul Srivastav. President-elect Rajasthan Orthopaedic Surgeons Association, Dr. Arun Vaishya. Treasurer, Rajasthan Orthopaedic Surgeons Association, Dr. Saurabh Mathur. And Scientific Chairman of this midterm ROSACON, Dr. Jain Sen. I welcome you all. I invite you on the dais and let us go for the lamp lighting and Saraswati Vandana. So I invite all the chief guests and esteemed guests for this. Thank you. I invite President ROSA, Dr. Rajesh Goyal, sir, for his welcome address. Dr. Rajesh Goyal, sir.
Good morning to all. Honorable President IOA, Dr. R.C. Meena, Chief Guest for this inaugural function. Honorable President-elect Dr. B. Shivashankar, he is the guest of honor. Honorable IOA Secretary, Dr. Atul Srivastav, President-elect ROSA, Dr. Arun Vaishya, Secretary ROSA, Dr. Rahul Katta, Scientific Convener, Dr. Jain Sen, and Treasurer, Dr. Saurabh Mathur. On behalf of ROSA members, I welcome you all for this first ever virtual meeting of midterm ROSACON today on Sunday. In the last week of March, our dreams were shattered. But then we rearranged, replanned, and reorganized. And it was the fruitful things that we were able to stream 12 webinars of different subspecialty. And we are today streaming first ever webinar for including all the 13 sessions in this midterm ROSACON. I once again welcome you all, sir. And I welcome all the delegates also. And I am sure that they'll enjoy this type of subspecialty meetings, including this and midterm ROSACON. Thank you very much, sir. Thank you very much.
Thank you so much, sir, for your kind words. Now, I would like to invite the scientific chairman of this midterm ROSACON, Dr. Jain Sen, who will enlighten us for the details of the scientific program, what today we are having. Dr. Jain Sen.
Thank you, Dr. Rahul Katta. Greetings to the President IOA, Dr. R.C. Meena, who is our chief guest, to our guests of honor today, President-elect of IOA, Dr. Shivashankar, and Honorary Secretary of IOA, Dr. Atul Srivastav, our President, ROSA President, Dr. Rajesh Goyal, our President-elect, Dr. Arun Vaishya, our Honorary Secretary, Dr. Rahul Katta, and our Treasurer, Dr. Saurabh Mathur. As Dr. Rajesh Goyal already mentioned, we were faced, like the rest of the world, with new challenges since the month of March. And late in May, it was decided that we would not be able to host the midterm ROSACON, which was scheduled on 12th of July. So the ROSA team took it as a challenge to keep the academics going and still hold the meeting on 12th of July. And we were able to do this with a virtual meeting. And I think a lot of hard work has gone in from Rahul and the technology team. So we have put a lot of effort. The scientific sessions have been designed in a way to cover all specialties and subspecialties of orthopedics. We have 2 sessions on arthroplasty, 2 on arthroscopy. We also cover spine and hand, pediatric orthopedics, orthopedic infections, and of course trauma. So it's going to be a very interactive meet, and because it's going to be the first ever, so we hope to have a glitch-free meeting. But please bear with us if we are faced with some challenges. We have tried to make an honest beginning, and we seem to have a record number of delegates registered for the conference as well as for the PG quiz today. The PG quiz will be held at about 1 o'clock, and we have nearly 80 postgraduate students from across Rajasthan participating in this gold medal section PG quiz. So welcome everyone, and we look forward to a very scientific and academic day. Thank you, Rahul.
Thank you, Jayant. Thank you. Now it's time to invite our guest of honor, President-elect IOA, Dr. B. Shivashankar, for his address. Shiva, sir.
Thank you very much, Dr. Rahul Kattaji. President IOA 2020, Dr. R.C. Meena, sir. Secretary, Dr. Atul Srivatsavaji. ROSA President, Dr. Rajesh Goyalji. Secretary, Dr. Rahul Katta. Then Dr. Jayant Singh, my friend, who is the in charge of scientific committee. My dear members of ROSA and all the delegates who are viewing this program online. For first time virtually, this digital orthopedic conference in the form of midterm annual meet of ROSA. Heartiest congratulations for having arranged such a wonderful conference with different halls, trade exhibition, etc. It gives a virtual feeling, not just virtual feeling, but also of having attended a high event. Friends, this pandemic corona has done lot of havoc, but corona se ladna hai, darna nahi. As the saying goes, there is always something, some silver line, even in the worst things this pandemic has caused to the mankind. First and foremost, all of us have become more computer savvy, and now all of us are much more well acquainted with Zoom meetings and doing online presentations. It has given us an opportunity to use this digital platform to reach every nook and corner of the world. For example, the PG IOA teaching program all these years had 4 or 5 speakers only and an attendance of about 100 to 150 students attending at one center. That too, 4 or 5 times in a year. But this year, under our President Dr. R.C. Meena sir, we have broken all the earlier records. We are having this IOA PG e-Pathshala every week, and the average viewership is more than 5,000 people, and we have viewers not only from India but also from other countries. Congratulations to IOA for this wonderful activity they are doing. Even the ROSA has already said that they have already done 13 webinars so far, and this is the conference they are organizing for the first time. This pandemic has exposed lacuna in our health system also, and has shown how badly we were prepared to handle this situation if the corona had spurt in January, February, March, or even April. Now we have a lot of local manufacturers entering this field of health services to manufacture PPE kits, masks, respirators, etc. So better quality products will be available for us in future at a fraction of the cost what we are paying now. Definitely it will go a long way in Atmanirbhar India. People now know that health insurance is not an expenditure, but it is an investment for the future to have good health. So spending on health has become an investment now. Government is also appointing a lot of doctors, upgrading its facilities like laboratories, ICUs, and spending a lot of money at present. Overall, for the health industry, Corona has played a role of mirror to show the real face of health services, and the government has woken up to a good change of its face. Just, I would like to once again congratulate ROSACON team for having invited me for this wonderful meeting. Thank you very much.
Thank you so much, sir, for your kind words of encouragement. Thank you so much. Now, I would like to invite our guest of honor, IOA Honorary Secretary, Dr. Atul Srivastav, for his address. Dr. Atul Srivastav, please.
Good morning, all dignitaries on the dais and dear friends. Well, it is indeed a proud privilege and pleasure to be attending the first virtual meeting of the midterm symposium of Rajasthan Orthopeadic Surgeons Association. I really congratulate the entire team for putting this act together. The team of Dr. Rajesh Goyal, President, Dr. Arun Vaishya, President-elect, Dr. Rahul Katta, the Dynamic Secretary, and of course, the mind behind Dr. Jayant Singh, the Scientific Chairman, and Dr. Saurabh Mathur. In the 5 hours that we are going to witness, we are going to touch almost all aspects of orthopedics, including arthroplasty, arthroscopy, spine, hand, pediatric orthopedics. And we are fortunate to have an esteemed faculty, and I'm sure at the end of the day, we'll all be wiser in orthopedics. I once again congratulate you all and wish you all a very happy and fruitful learning. Long live Rosa, long live IOA, short live Corona. Jai Hind. Thank you.
Thank you, sir. Thank you so much, Dr. Atul. So, I would request Dr. Arun Vaishya to the President-elect Rosa to say a few words.
सर कोई बात नहीं, एक बार और ट्राई कर लो, बिगर फोटो के ट्राई कर लो.
Arun sir, unmute yourself, please.
जो लिंक थी कर लो सर, बस आप ही कर.
Good morning, friends. I would like to welcome on behalf of Rosa, midterm ROSACON, Dr. Shiva sir, Dr. Atul sir, Dr. Rajesh Goyal sir, my friend Jayant, Rahul ji, and Saurabh. It's indeed a very pleasure moment for all of us being a ROSA members. And I'm very happy that because of the efforts of the whole team of the ROSA, we could have this virtual first of its kind of ROSA of Rajasthan Orthopeadic Surgeons Association. And we'll be having around 12 to 13 sessions. And I hope this whole webinar or midterm ROSACON would be very fruitful, would go in a long way for the upcoming orthopedicians. And I welcome you all and thank you so much for joining with us and encouraging for this webinar. Thank you.
Thank you, Dr. Arun Vaishya, sir. Now it's time to invite our chief guest, President IOA, our own ROSA member, our own Dr. R.C. Meena, sir, for his address. Over to you, Dr. R.C. Meena, sir.
Thank you very much, Rahul, for giving me this honor. The respected President, Sir Rajesh Goyal was President-elect, my student, my friend Arun.
Sir.
And our honorary past President, Dr. Vinay Joshi, Secretary General of ROSA, Dr. Rahul, Treasurer Saurabh Mathur, and our dynamic team from IOA, President-elect Dr. Shiv Shankar, Secretary Dr. Atul Srivastav, and organizing team head Dr. Jayant, Dr. Solanki, and the learned faculty from the country and abroad. And dear friends, not in the list, but those who are connected with this virtual conference. Good morning, friends. It gives me an immense pleasure to welcome you all for the midterm ROSACON, which is the midsummer meeting of our August body, ROSA. And most, I must re-emphasize that I am a ROSA member first, and is like that. ROSA member first, and the visionary leader and our senior brought up and built our state association from scratch, and it's heartening to see our association in its vibrant and robust form. Even as President, I can proudly say the ROSA midterm meeting has all the ingredients of academic. And meet at a high-end scientific get together. Friends, time are desperate. We are dealing with an unprecedented crisis which has never been seen, never has been assumed with the COVID-19 pandemic. I was never prepared for such a huge crisis in the beginning of my presidential tenure. I can confidently that we generated 15 lakh rupee fund from the various sponsors, among the biggest is the color, within no time, and distributed his mask and shield to all my Kanyakumari to Kashmir army truck and convey shipped in to help us this humanitarian cause. Are you hearing me?
Yeah.
Hello?
Yes.
And with support from the unexpected quarters, we are able to reach out the remotest area of the location. At our state level, our Honorary Secretary Rahul Katta played a humanizer of a role to ensure a smooth distribution of bioprotective equipment. Friends, in the end, I would like to welcome all the delegates and faculty and congratulate the organizers putting together a web meeting is a difficult time. Of course, I would like to say here, maybe since I have a good quality of network, I may have a poor quality of network that you have seen in front of you while I am sitting in the heart of the state or Rajdhani of the Rajasthan, Jaipur, but I am still not connected. But I try my best to again connect you. So friends, enjoy the celebration and stay safe. All the best, organizer. Keep up this momentum. All the best, Dr. R.C. Meena, President IO. Thank you very much for giving me this honor again once again. Rajesh, sir.
Thank you so much, sir. Thank you so much for your kind words and words of encouragement. Now, actually, we are running late, so I will not take much of the time. So this is a webinar a scientific feast, which we have tried to organize in difficult time with various sessions that Jayant has already elaborated. So there are 12 different sessions. So in those sessions, we have more than 25 international and national faculty members and more than 80 local faculty members, and more than 50% of them are the young orthopedic surgeons who are going to present their good quality work. We have 12 different moderators for different sessions who have worked very hard to organize and to present the great scientific work and the content in different sessions. So I'm thankful to all the moderators, guest faculty, local faculty for working hard and making it a good scientific feast. There are a good number of delegates who have already registered for this, and I hope many more will join this academic feast. And I think this would be a feature for the conference in the difficult times. Thank you so much. I'm really thankful to all our esteemed guests, our chief guest, Dr. R.C. Meena, sir, our guest of honor, Dr. Shiva Shankar and Dr. Atul Srivastav, who has spared the time on the Sunday morning to join us for the inaugural ceremony. Thank you, everybody. Now we must go for the national anthem.
Jana Gana Mana Adhinayak Jaya He Bharat Bhagya Vidhata Punjab Sindh Gujarat Maratha Dravida Utkala Vanga Vindhya Himachala Yamuna Ganga Chala Jaladhi Taranga तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे जय गाथा जन गण मन मंगलदायक जय गाथा जय हे जय हे जय
Jai Hind. Now we have to start the scientific sessions in both the halls.
I invite Dr. Vijay Bose sir for a talk on bearing surface in THR, especially in young population. Thank you, sir.
Yeah. So, firstly, thanks very much for the organizing committee. I think it's one of the first conference ever to be online. So, congrats for that. Thanks very much for inviting. So, generally in our country, we do arthroplasty on very young people. So, talk about the young. I think we have to be more selective. And I'm going to talk on the children. So, it has some different principles. And whenever we are doing hip arthroplasty in children, we are grappling with the medical and non-medical issues. Sometimes the non-medical issues are much more dramatic than medical issues. So the hip arthroplasty in the very young is not entirely new. A lot of Western literature with regard to inflammatory arthritis has been well described. So here's one of them. There's very common JRA, juvenile polyarticular rheumatoid, and this particular paper, which is a 2012. They say that the survival of ceramic on ceramic is far better than metal or ceramic on polyethylene in this very young age group. And there have been literature since the 80s onwards, but all the Western literature is always with regard to JRA. However, there are key differences in the Indian or the Asian population, and this we call as the Asian paradox. Here, polyarticular inflammatory arthritis is relatively uncommon. We usually have solitary hip disease, condylosis, AVN, coccyspinal, angstpon, etc. These are normal activity individuals. And the Asian paradox, we have very small acetabulum size and femoral size. However, the cultural compulsions in Asia are much more. They need to sit on the floor, etc., as we all know. And female patients will require near normal hip function for marriage and pregnancy, these children as they in life. And more than one revision surgery likely to be required. And this certainly is a high-risk situation, not to be taken lightly. So the first question you have to ask yourself is, are we justified in taking on this high-risk situation? Should we be doing arthroplasty in children at all? So there is a golden rule of elective surgery, not only orthopedic surgery, but all elective surgery put together. Do the risks outweigh the benefits? That's the first question that you have to ask yourself. Every patient must ask this question when you're operating arthroplasty in children. So this is a 15-year-old patient. She was referred to me by a very famous pediatric orthopedic surgeon in Chennai, 2007. Now, I thought she didn't have enough symptoms, so I didn't operate on her. She came to see me this year. So she's now 28 years old. The X-ray looks the same. She's now working in Singapore and she's fine. So this is the best option. Just because the X-ray shows something in children, you certainly must not operate on them. So we have developed a criteria. When we operate, the child must be unable to attend school because of the hip issue. And then you have to take it on. Because if the child is not going to school, then what's the point really? So if we are going to have issues later on, we'll face it. But the child has to get to school. So in this situation, more than one revision surgery likely to be required. So it should be dealt with great caution. Patient must be grossly disabled before offering the procedure, as I said, unable to attend school. Surgeon must be confident of perfect compound positioning in spite of gross multidimensional pelvic deformities. Because these kids have a lot of very flexible spine, they'll be able to accommodate a host of deformities. So you must be careful of that. Technical mistakes may cost the entire life of the patient. Patient and surgeon must understand the long-term implications of this procedure, and he must not treat it lightly. The first question, are we justified in taking on this high-risk situation in 2020? I think we are, because we have got three important advancements. We have the delta and delta bearing, which seems to have almost negligible wear. We have the large heads 32 and 36, which gives us normal function that these patients require. Some of the kids will even forget that they have surgery. They'll be climbing trees, etc. So it's important to give them function. And the most important point that I want to cover today is we must do bone conserving surgery so that we can make revision 1 or 2 easier. So because we have the three tools now, we think it's justified today to take them on. So here is my series of arthroplasty in teenagers, 83 patients. By teenagers, we mean 19 or less. You can see that. And so far we've done 83 of them. So delta and delta bearing has been really a big advantage in these patients. Conventional poly, as we know, a lot of wear, but this recent paper from HSS Amar Ranawat's group, which is even if it has a cross-linked poly, you can see the wear there. Yeah. So poly has its, especially in the young patients, I think ceramic on ceramic bearing scores over cross-linked poly. So this is the the comparison between this with this. And when you find that in young patients, now it is longevity, we're not talking about 20, 25 years anymore. With delta and delta, we're talking 40 plus years now. So when you do on somebody who is 17 years old, we got to look at a very long time. And then we find that the particles, particulate debris, ceramic and ceramic is much less than cross-linked poly, although cross-linked poly clinically does not produce oscillates in most patients. In this young group of patients, we really have to make a distinction. And here is the paper saying that we find that if you have any type of particulate debris, apart from oscillates, it may actually affect the muscle, cause degeneration by preserving muscle progenitor. So ceramic on ceramic maybe scores over cross-linked poly in this very young patient. Larger technology. We always use a larger technology whenever we can. And here, a 17-year-old girl, and these kids will forget that they have any surgery, and they will do all that similar kid of the same age will do. So you got to be careful of that, and you have to give them a larger option. So no activity restrictions. You cannot enforce activity restriction in this age group. Yeah. But the most important concept I want to cover is the concept of bone conservation in these young patients. Bone conservation, immediately people think that we put short stems. Not at all. It's got nothing to do with short stems at all. Now, whenever any talk, when surgeons cover classification of stem, they talk about it has got one taper, two taper, etc. Proximally coated distally. That's all irrelevant. From a very functional standpoint, what is really important when you're operating on young patients? Most of our patients are young, by the way, in India. What we are looking at is choice of stem. Can this stem be removed without ETO? That's the important question you have to ask yourself in a young patient. Or when I have to do revision surgery for the patient, should I remove it with an ETO? That's a fundamental point. A lot of surgeons have not yet understood this. So a low profile tapers, as we call them now, can be removed without an ETO. I'll show you that in detail. Yeah. Whereas even if it's non-symptomatic, if you have a high profile stem like the Synergy from Smith & Nephew or Summit from Depew, you cannot remove them without an ETO. So, or a simulated stem. I have nothing against simulated stems. Simulated stems works very well. But for this reason, I do not use simulated stems in young patients because you need a ETO. Now, why is it so important? Because if this fails, then I have an option of using a short revision stem less than 190 or a SROM stem. And then if it needs a second revision, I would use a traditional revision stem. Whereas once you use an ETO in the first revision, you are bypassing one step, a very important step. And thereby, I think you are losing 30 years in that entire life cycle of that patient. So here is what we mean by your choice of implant must have 3 good bites of the cherry. So remember, the femur has got a nice taper proximally. The mid portion is a cylinder, and in the distal third is a reverse taper. Yeah. So when we use a low profile taper like that, we get the fixation, and that's why it must be a low profile taper. You must not violate this in your primary surgery. So a short stem has got no advantage over low profile taper. So that's the reason I do not use short stems. Now, first revision, I would use a short revision stem, 190, and thereby I use half of my cylindrical portion. Now, an SROM, again, would be a great option for a first revision surgery. When the patient comes for a second revision surgery, you still have diaphysis where I can get contact. So I have given provision for 2 revisions. Of course, here we cannot get any fixation. So with our modern bearings, if we say each one lasts for 30 years on a conservative estimate, 30 plus 30 plus 30. And that, I think, gives us the confidence to take on this. No matter what the age is, I now have the confidence to take on these patients. Because even if it's a conservative estimate, I don't think I have to give provision for more than 90 years. So I have I have sorted things out for 90 years. Here's a comparison of 2 types of primary stems. Here is a surgery done elsewhere. They've used a high-profile stem. Bad idea in young patient. And this is what I did. Those days when ASR was popular, both these components are ASR. You can see the difference between a low-profile taper and a high-profile taper. Both are non-symptomatic stems. So both needed revision because of ASR problems. And I was able to remove this without an ETO. And therefore, I had a conservative revision. This needed a big ETO and therefore had a very compromised revision. So key difference between these two patients. So that was the stem that we used in this one. We used a long post-ETO stem for this one. So the other important point is just not the low profile taper that you are using, but you must also use it in the correct principle of preserving cancellous bone. So you must find that you must always have cancellous bone. You must not fill the canal. That is so important. A lot of junior surgeons do not understand this concept. So all my X-rays you will find, it will not be tight fitting. I mean, sorry, it will have very good stability, but it always have compacted cancellous bone. All my X-rays will look like this. And revision becomes a breeze. Now, the Ortho group has very well described that instead of cement, when you're using non-cemented stems, you must have cancellous bone. If you have HA also neotrabecular bone. All these three things must be in the place of cement. It's not just metal in place of cement. It is cancellous bone, compacted cancellous bone, HA, and neotrabecular bone that must take the place of cement when you're using a non-cemented stem in a young. So this is somebody else's X-ray. You can see how the canal has been filled up. This probably would need an ETO to take it out, although a low profile taper has been. Well, this is a very wrong concept and must be avoided. So you can see how the stems preserve cancellous bone. You can see that you must have a rasp that's bone conservative, and when you're rasping, you must compact bone and not remove bone. And thereby you can see all the compacted bone. And this is very critical so that you can have further revision becomes really a breeze to do. And you can see all my X-rays like that. We have not had any failure of stems like this. Again, preservation of cancellous bone is absolutely. Case example here is a CLS stem, again low profile taper. You need to have these instruments to extricate it, and then we are able to take it out quite easily without an ETO. And thereby, we're using a conservative revision as our first revision option. Now remember, the hip has got two sides, so you can be as bone conservative as you want. Use short stems on the femoral side. Waste of time if you're not preserving acetabular bone. So it's equally important. So this is the same three good bites of the cherry you need. The first time you must never use a highly porous cup. A lot of people use highly porous cup unnecessarily in primary surgery. Must seriously be avoided in young patients because revision. So we don't use a highly porous cup. We use a standard cup. The important thing is to be of native size. And then we use for the first revision a press-fit cup which is 2 to 4 millimeters larger. And only when we go to the second revision where we need a jumbo cup or a tantalum or whatever, then we use a highly porous cup. So this must be your concept of.
Dr. Vijay, actually, we have very short time. Please summarize.
I thought it's 15 minutes.
Yeah.
Okay, so I will stop then. This is an example of a conservative surgery.
Vijay, you can take some of my time. It's okay. Carry on.
No. Thank you.
No. I was given 15 minutes, only 12 minutes now.
Yes.
Yeah,
so Vijay, you can go through your talk completely. We can do one case less.
Oh, no. No, we should not do cases. I don't think so. But anyway, I'll rush through that. So here's a patient. You can see the post ASR. And I have revised it again for ASR revision ratio on the right side. So the revision socket has been 2 millimeters higher. The index socket is 50. I revised it. That's how you must do the first stage revision. You are maximum allowed to go 4. For whatever reason, if you go 6 or 8 in your first revision, you're doing a great harm to the patient. It's a great harm. I would say it's negligent. So you must have the correct tools. You must do it. You're allowed to do only a 2 or a 4 millimeter increment when you're doing first revision surgery. And again, I keep saying this concept that the acetabular component in the primary surgery must never be more than the native size. Native size is the other side. It must never be more than that. You must not put a socket that's big. Very important. Here's an example. The primary surgery has been done. I don't have the X-rays of primary surgery, but this is the second size the patient came to me. And I've done, this is the size, native size of the cup. The surgeon, other side, has used a huge cup. Big no in young patients. So you must respect the native size of the acetabulum. Absolutely critical. So here is an example, 70-year-old patients, all these things. We use the same principles. Look how conservative the stem is, how conservative the socket is. And that is the concept. More than the implants, you have to do conservative bone surgery. And if you today remove a cup without an explant, I think that is negligent. So now post the 15-year-old patient, you look at the size of the cup, small cup, easy for revision surgery. Here's a 12-year-old patient, idiopathic chondrolysis. Look at the size of the cup, look at the conservative bone stem. And they're allowed all activities post. She plays kabaddi in school. This is another patient, again, same principles. 17-year-old patient, same principles. 16-year-old patient, same principles. This is the point I want to make. So this is the papers from literature. You can see how they have done on young patients, 21 years. But look at these stems. Negligent. I mean, no one can remove this. You probably need a total femur replacement when you want to do these stems. Absolute no. Although these are from very reputed centers, wrong surgery has been done. I have to say, very negligent surgery has been done. You cannot do this. You can absolutely. Look at another one. Again, for young patients, look at the stem. Big mistake has been done from these reputed centers. So please do not repeat those mistakes. So in our series, we have 83 hips. We have got 2 revisions. This is the first case, 11-year-old girl had a BHR when she was 11 in 2004. And that is the BHR. And 14 years later, she had the pain. X-ray looked normal. I revised it to a SROM with a ceramic head and a dual orbit, retaining the cup. So very conservative revision. Revision 2, an young girl with this protrusio rheumatoid arthritis. The mistake I've made here is I have undersized the SROM stem. So the SROM stem became loose. I revised it with another SROM stem. So the point I'm making is that both is revision surgery, post-revision surgery, these X-rays can be passed off as primary surgery. And that's the whole concept of conservative revision surgery. Both can be passed off as primary surgery. So this is a recent email I got from a girl who is only 10 years old. The question is, how much can you push? Can you push 10, 9, 8? We really don't know the answer. We have to wait and see. So this is just coming to India. These are all the patients who Kuhn dispersed patients who had ceramic on ceramic reserve. This is going to open a complete new chapter in reconstruction of the hip in the young patient. So in summary, I'd like to say we now have the tools to address end-stage monoarticular post-articular disease in very symptomatic teenagers. Surgeon and patient must understand long-term implications, and provision must be made for more than one revision surgery by adopting a bone-conserving philosophy. We are very happy that based on our experience, specialized centers the world over follow our guidelines and principles and offer hip reconstruction surgery to youngsters is truly life-changing. I thank you for your attention. Thank you very much. My apologies for taking 1 minute extra. Thank you.
Thank you, sir. Excellent presentation. Now I invite panelists, Dr. Vijay Bose, Vijay Kumar sir, Dr. Rajiv Bhargav, and Dr. S.P. Solanki, and Dr. Anup Jurani. The first case, I invite Dr. Kuldeep Nathawat for THR in AV and HIF.
So, good morning, everyone. Am I audible to all?
Yes, hello? Yes, you're audible.
My screen visible?
Yes,
my screen visible to all of you? Okay, thank you so much. So, again, once again, good morning.
Thank you.
And we will be discussing few cases, if possible in 8 minutes, 2 or 3 cases of total hip arthroplasty in avascular necrosis of the hip. So let us take the first case. There is a 32-year-old male. He is a hospital manager by profession. He has bilateral AVN for past almost 1.5 to 2 years. Left is more symptomatic with regular pain and limp. He needs regular painkillers as he is in hospital, so he is habit of taking the painkillers also. He has a history of core decompression in left hip 6 months back, after which the pain in the left hip has increased after the core decompression. And because of that, he has severe restriction of his activities of daily living. So let us take this case. At the age of 32 years with core decompression and more painful left hip, what should we plan for this patient? So should we conserve or should we operate? My question to the panel. I should ask Dr. Jurani the first question, sir. How you should take this patient?
Can you go back to the pre-op X-ray, please?
This is the pre-op X-ray, sir.
No, depending on his pain and functional limitation, definitely this stage 4. So I don't think there is any room for conserving if this patient has got regular pain, is need of painkillers. Mm-hmm. There should be no hesitation to operate a 32-year-old male with current bearing options. You can give a 20 to 25-year-old result. So, yeah.
So, coming to just elaborating few options, like we have few theoretical options. Dr. Vijay Bose and Dr. Solanki, sir, do you advise giving bisphosphonate to these patients before surgery?
Yeah, not for these patients, but early AVN. Whenever we diagnose, we find it's got a very high success rate. So we use bisphosphonates in all the patients described by Dr. Agarwala from Mumbai, and it works extremely well. But not for this patient. This patient needs a THR.
Yes. No, for left he needs THR, but for right to delay is because right is very less symptomatic. So to keep the right going and to do the left hip, should we give bisphosphonate preoperatively?
Absolutely, yeah. So bisphosphonate up to 1 year has got no side effects.
Okay.
We must give bisphosphonates. No question about that. Yes, along with calcium and vitamin D.
And how many of you advocate these electrophysiological modalities like electrocorporeal shortwave therapy in early AVNs stage 1, 2, or sometimes 3?
Well, to put it in short, apart from the bisphosphonate, there's no evidence for any other method of treatment, including all these stem cells and all that. No scientific proof.
So that is correct. That bisphosphonate do have a role because of osteoclastic activity to delay the total replacement and keep the patient pain-free. Although radiologically progression may go on, but because of inhibiting osteoclast activity, patient remains in less pain, or you can say in better activity level because of bisphosphonate, and can delay the total replacement. And simultaneously, the literature also advocates the use of antioxidant vitamins, calcium and vitamin D. So as Dr. Jurani has rightly suggested, we took this patient planned for THR, and we did not waited and do the left hip for this patient. And preoperatively, we have given him a zoledronic acid 3 weeks before. So it is like zoledronic acid should be given 2 to 3 weeks before, so that we can plan for the next surgery. Coming to the next case, and this was his intraoperative, just to share that although radiologically it does not look that degenerated and there is a maintenance of joint space, but intraoperatively the head is completely collapsed and crumpled. Coming to the next case, this is a 42-year-old male, 2-year-old operated fracture neck of femur. The head goes in AVN and subluxates laterally, tries to come out of the acetabular, and patient comes with severe pain, limb shortening, and activity of restriction of daily living. So my question to Dr. Vijay Bose, sir, how we should plan this case and what precaution we should take, especially while dealing the acetabular side in this case?
Well, 40-year-old main completely collapsed head. So I don't see any challenge on the socket side. A bit of superolateral defect, but the challenge is really on the femoral side. And all these screws may actually have a problem. You can remove the screws carefully, and they have sclerotic bone. They need to have a high-speed burr. Take care of that. The socket is usually not a problem in these cases.
Jurani sir, as the socket is oblong, it is degenerated as a posterior superior defect. So sometimes for the beginners, it is difficult to locate and go with the original socket. So what tip do you give for the beginners so that they keep the native acetabulum at the anatomic site?
Right. So it's very important to identify the transverse acetabular ligament and not chase the head, because head is subluxated superolaterally. So if you start reaming, you will change the center of rotation. So you really need to come down, see the tall, and get the hip where it belongs to restore the normal center of rotation. And that will also make a tight reduction, because this patient has been short for quite some time now.
Yes.
So you have to be careful that the reduction is going to be a little tight. But you got to get the center of rotation to its normal level, do the necessary releases, and then have a nice stable hip.
So I think these are the two most important points we should consider. On femoral side, sometimes taking these cancellous screws becomes difficult, and at times we do have problem in taking out them, and we should have the diamond drill bits and all those hardwares in our hand. On acetabular side, we should keep as points as suggested by Dr. Jurani. So the fibrous tissue from the native acetabulum should be removed gently, and the native acetabulum should be exposed at 360 degree, and tall should be identified before starting the preparation, and then we should put the native acetabulum. This has been done post-operatively, sir. Coming to the posterior superior defect should be left untouched, because although that side acetabular cup will look like uncovered of 10-15%, but that does not matter. Coming to third case, sir, this is 36-year-old female complaining of severe pain both hip with inability to walk. She came in wheelchair for past 6 to 8 weeks now on regular painkillers, and she has a history of steroid intake. So my question to the panel is, what is the consensus of doing stage surgery or single stage in this patient, female patient, 38-year-old? How many of you do single stage and how many of you do stage surgery, sir?
No, yeah. I think we normally do, a single stage surgery if both hips are symptomatic and both hips warrant a hip replacement. So, and especially in a young patient, this is a young patient, is 38 years old. So I don't think there's any, you can easily do single stage surgery, and she should not have any comorbidities and all the other things that
No, she is fit. She don't have any comorbidity.
Yeah.
She has some skin issues. For that, she took steroid for longer time. Other than that, she don't have any.
Yeah.
Dr. Jurani, what is your consensus for this patient?
Dr. Jurani wants to add something.
Yeah, so I would not hesitate to do a single stage bilateral in a male patient, good hemoglobin, ANC is spawned. But in a female patient, especially if the rheumatoid patient, though she is not a rheumatoid, if the rheumatoid patient with the rheumatoid lung on DMRDs, I would do a stage surgery. So there is difference between a male and a female and the comorbidities.
So we need to consider the metabolic cause as well. You mean to say that?
Metabolic, systemic, lungs especially, and the hemoglobin and the general well-being of the patient.
Yes. Porwal sir, what is your take on this? You would like to do single stage or stage? Dr. Porwal, am I audible to you?
Yeah, yes, now. Mute was na pura unmute kiya. I will do a stage surgery. Stage is not a single stage.
Okay. So what is the, because both hips are symptomatic, so those who are advocating stage surgery, how much should be the ideal time in between two surgeries we should consider? We should keep.
Yes.
How much the ideal time if we are planning for stage surgery? What should be the ideal gap between the two hips, because both are symptomatic?
Yeah, theoretically 6 weeks. Practically, when the patient comes, a lot of relatives come, insurance, everything, it could be 4 to 7 days, though literature says that's not a great idea. So ideally 6 weeks, but when you come to ground realities, it can be 4 or 5 days also.
That's correct. So literature advocates 3 to 6 weeks, but we have certain other foundations also. So we did this patient in a staged manner at a gap of 4 days, and this was a post-op. So I think these are the 3 different cases we have taken for avian. One is after
Vijay Bose to add on anything, expert.
So, sorry.
For the bilateral avian hip in a young lady.
Yeah, I'd agree exactly with what Anup said. Ground realities. We have done always, 3 days later, 4 days later. I don't think there's any difference. You can do it whenever you want to do that.
Correct. So the message for avian hip is that not all avian hip needs arthroplasty till Ficus Tarlet stage 3 or 4, or patient becomes continuous symptomatic, especially with respect to pain and restriction of activities of daily living. And the most important thing we should consider, because we are getting more young patients with avian and arthritis, advanced collapse, that continuous pain and activity restriction should be taken as a primary consideration to plan the patient for surgery, rather than giving importance for radiological findings like MRI and other things.
Thank you, Kuldev. Very nice presentation and panel discussion. Now I invite Dr. Anup Jurani sir for next dysplasia hip.
It's good to interact again with friends and colleagues. Both Vijays, one from Chennai and one from Delhi, very dear friends. And of course, all the colleagues from Rajasthan. So what I'll do is I'll present my case, and then we can take some critical discussion after that. So this is a 22-year-old lady.
Anup, you need to do this thing.
Okay.
Yeah.
Can you all see it?
Yeah, we can see it now, yes.
All right. So 22-year-old lady, we can describe her young. 22 is pretty young. And she had this osteotomy when she was a child. The history papers weren't there, but about 10 to 12 years back. And we can see the plate there. We can see the osteotomy. And we need to analyze this X-ray very carefully. Obviously, this is a type 4 dysplasia. The head is way up. The socket is small. The femur has got a bow. So putting the stem will be challenging. Removing that old plate could be a challenge because there will be machine screws, not the normal screws. So one need to have that screwdriver, the machine screwdriver. So the steps will be to remove the plate, plan the osteotomy, put the cup where it belongs because it's type 4. In type 2 and 3, you can use a higher hip center, but in before you need to get it down. And then use a SROM stem. Mostly we'll be able to take the SROM stem, though it'll be a challenge to put it. So the insertion point won't be here, but it will be here. And this part will be very tight. So we need to have all the stem sizes available. So that's the kind of analysis of this X-ray, very careful planning and implant selection. That's the old scar of the patient. And that's the kind of deformity that the patient has, a fixed flexion deformity. You may need some releases. Vijay says that in type 4, we don't need releases. Yes, we don't. Once we do the osteotomy, sometimes you may need an iliopsoas release, because iliopsoas crosses the acetabulum or pelvis and comes into the femur. You may need it. Right. So this is the way it looks on exposure. It's a mushroom kind of a head, nothing practically there. And you remove it and prepare it according to the SROM stem. Before that, you remove the plate. It was not very difficult, but you should have Midas tools available in case a screw is broken or is cold welded. So you remove the plate, get it out of your way, then expose the socket. That's the key. And the socket is very small, filled with fibrous tissue. We need to identify the transverse acetabular ligament. These sockets generally don't take more than a 40-42 cup. Usually it's a 38 cup, 36 cup. You should have bantam cups available, small sizes, and you don't ream too much. You just do 1-2 careful reaming. The last reaming has to be a reverse reaming so that you are not expanding the socket. Best to identify under the C-arm. I still do it so that you know that you are right near the teardrop and your cup is in right orientation. Your screws are in good orientation. I would like to have 2 screws and a highly cross-linked poly. I would keep seeing under the C-arm what I'm doing. Then comes the osteotomy. So you do the osteotomy, and in this particular case, the trick is, because the femur is translated, is to reverse the sleeve. We can discuss that, how to do that, but to reverse the sleeve, because if you analyze the pre-op X-rays, you cannot put the sleeve where the normal calcar is. So, just a minute, yeah. So do the osteotomy, put the sleeve reverse, and then do the osteotomy, take the proximal fragment, reduce it, overlap with the distal fragment, take the necessary part out, and then put the stem in. And whatever osteotomy part you have, you can sleeve around the osteotomy and hold it with one wire. I'd like to share this video as how stable your osteotomy is, provided, sorry for that, I'll just lower the voice of this video. Sorry for that. Yeah, I think I got it. Yeah, okay. So now you can see, once you get the right fixation distally, you don't need any adjuvant fixation. And you can see that the osteotomy is solid. You can move the whole limb with that SROM stem with no adjuvant fixation. And since there is no calcar and there is a translational deformity proximally, we have reversed the sleeve. This is the only indication of doing a reversal of sleeve. Okay, and that's the final X-ray. The follow-up, the patient is still under follow-up. So you can see the cup, slight over-reaming, slight, but you don't need to do that. But you need to get good coverage of your cup, 2 screws in the right direction, SROM stem. The most important point here is great distal fixation. If you don't have good distal fixation, you will have a non-union of the osteotomy and the sleeve reversed because of the reasons that I outlined earlier. Now, if you want, we can have some critical discussion on this case.
Yeah, ask for the cup size. What is the cup size?
Naresh, I don't remember exactly now, but I think it was 42.
It's a multi-hole cup. Which companies you use?
This is a Gription cup.
Gription cup.
Yeah, Anup, it's an excellent case. You outlined all the principles of dysplasia, right to you picking the hip center in a grade 4 dysplasia to the original one if possible, and how to do do an osteotomy and specifically, reversal of your sleeve. So how often have you had to reverse the sleeve? Means, just, or Just for the audience.
Yeah, I've done it 2-3 times, especially in cases in which there is a translational deformity of the proximal femur, and you can't put the sleeve. You can see there is no place to put the sleeve here, and that's why I put it reverse. It's not as difficult as it looks, actually. So, yeah.
And how about using a cone type of prosthesis instead of a strong for such type of case, where you would not have?
Yeah, that's right. So it's very important to differentiate where you would use a SROM and where you would do a cone Wagner. So in case there is a big mismatch and you can't put a SROM stem distally with the sleeve, the sleeve. So SROM has a 6 difference. So suppose you have a 9 stem, you ought to put a 15 sleeve. So if there is a severe metaphyseal diaphyseal mismatch and you think you will not be able to get the right size of SROM, then that's a good case for a cone Wagner.
Yeah.
Anup sir, there is one question from the audience. The two Stabler screw in what orientation, sir, especially in dysplasia case?
Yeah, so I would mark, this is a left side hip. So in a left side hip, it is between 11 o'clock to 1 o'clock. So you put your cup accordingly so that you get at least 2 screw holes between 11 and 1. I would mark with methylene blue. I would mark my cup with methylene blue on the socket and the cup, and then I would match those 2 marks exactly so that my cup goes in a direction where I can get 2 screw holes for those 2 big screws, at least 30 and 40 millimeters.
Thank you. Thank you, sir. Excellent case presentation. Now I invite Dr. Abhay.
Any specific tips and tricks for the soft tissue release in this case?
Sorry?
How much difficult you find out while during the surgery for the soft tissues?
Naresh, in type 4, it's not a problem because you do the osteotomy to reduce it. So you generally don't need soft tissues release. But having said that, there are certain cases where you're using a 36-38 cup and then you're using a 22 millimeter head, and with DePuy you just get 122 millimeter head. Now there you have to be very careful because if you do more osteotomy, then you will be loose.
Yeah.
So this is a 28 millimeter head. So this is a different option, but you have to be careful that you don't over osteotomize it.
Yeah.
How much? Hello.
Yes, please.
What was the final limb length discrepancy? Was there any?
Sir, this is the early post-op X-ray, and there is a pelvic tilt, and there is an apparent leg length discrepancy with the operated size appearing longer. But usually they do remain short because you have osteotomized it. This girl at 1 year follow-up has about 1 centimeter shortening actually still because you've done the osteotomy. It doesn't appear on this X-ray though.
Great job done. Great.
Very nice. So, thank you, sir. Now I invite Dr. Abhay for the next case.
I need to stop sharing just a second. Okay.
You generally just share view of X-ray.
Only 45 minutes.
Okay, good morning. Can you hear me?
Yeah.
Yeah, we can hear you.
Yeah. So this is a straightforward, simple ankylosing hip. So I'll just do the questions in between as well. So that's a 21-year-old male that we are talking about. Had history of morning stiffness lasting 40 minutes, difficulty in walking, restriction of bilateral hip movements for the last 2.5-3 years, backache while sitting and getting up from sitting position. She has a disturbed sleep for posture, is unable to sleep on the right side, has difficulty in sleeping supine, and dropped out of his school/college about a year back. So on examination, this patient has a bilateral FFD of 45 degrees. There's no extension. Abduction, adduction is just a job. Has a painful hip. More than just the hips, he has pain in the spine and in the knees. Has a Harris hip score of 67. We did a WHO and a SF12 as well. Has an ESR of 11, CRP of 4, HLA-B 27 positive. And we did an ASTAS score for him, so he has a high disease activity. And we diagnosed him as a case of bilateral angstpon. So that's the patient view. And those are the preoperative X-rays. Those are the lateral views. So my question is that what are your pre-op considerations? So can I start with Vijay?
Yeah.
So a lot of these patients are on DMRDs. So Vijay, very quickly, will you stop DMRDs and what is the consensus on DMRDs?
Yeah, the biological needs to stop, that's all. If they are on a biological therapy, that needs to stop, yeah.
Absolutely. So the earlier concept of methotrexate being stopped 2 weeks earlier is now gone. You can continue it to surgery and biologicals need to be stopped. So those are the only DMRDs. Anu, any additional workup from surgical or anesthesia standpoint would you like to do?
Absolutely. So this is the Ankh-Spont patient, right?
Right.
Yeah. So you need to have the cervical spine. You need to see the chest X-ray, chest expansion, and of course the thoracic and the lumbar spine. For any occult fractures, cervical spine to see the fusion and the anesthesia plan, chest X-ray to see how much expansion it is, and that's important for the anesthetist, and the lumbar spine to see the spinopelvic association.
So when you said pseudarthrosis on the spine, what exactly do you mean? And does it have a bearing from the anesthesia or a surgical standpoint?
Absolutely. So these patients, there are some case reports, one from Vijay's institution in AIMS, and that's often quoted everywhere. The patient landed up in paraplegia. And I think there are a couple of other case reports also. So you need to identify that. And because the spine is very stiff, you need to position the patient very carefully yourself. And from the anesthesia perspective, the cervical spine, they need to do fiber optic intubation very carefully though.
Absolutely, very, very important. You need to be taking care of very good points here. So you need to be very careful with cervical spines. You need to have your anesthetist team with very good, very well versed with the endobronchial intubations. And you need to look for discovertible lesions, the Anderson lesions in the spine. So you can have paraplegias post-op if you don't take care. So those are the spine X-rays, nothing to remark. So no discovertible lesions. In your preoperative planning...
Vijay, I think, sorry, Abhay, can you go back on those X-rays? I think there's something worth noting there.
Yeah, so sorry for the name on that left X-ray. Yeah, any comments, Anu? So basically, I'm trying to put this for the discovertible lesion. So we'll talk about the pre-op planning down the line. Then
yeah, the lumbar spine we can discuss later. Yeah, all right. Go on, go ahead.
So, Dr. Bose, these Ankh-Spont patients, they are usually young patients. Usually pain is not just the only reason why you would operate them. So would you do them single stage or would you do them bilateral? And how will you decide between the two?
Well, we keep, not that it is a strict rule that you must do bilateral for all of them. If you find that it is a difficulty in mobilization or in per-op positioning of the patient, we will do at same stage. Otherwise, now that bronchoscopic intubation is pretty straightforward, if we need to sort of stage them by a few weeks, we don't worry too much about it as well.
So, in case you need to do them single stage, what approach would you use? Would you change your approach if you are a posterior surgeon, or
no? We don't change the approach. These are complex cases, especially with spinopelvic derangements. So we stick to what we are very good at. So we will use only the posterior approach. The only exception being, when it's in full external rotation. If it is in full external rotation, we'll do a dual approach. Otherwise, the thing would be from posterior approach.
Absolutely important. It's very, very important to remember that you've got to stick to what works in your hands, and you can very comfortably position the patients in lateral position, even if you've done a hip. Just be careful of padding the bony prominences. So, which side would you do first? Would you want me to go back to the X-ray? Is there a guide to which side you would do first?
We would do the more symptomatic thing first, and another criteria we try to do the more shortened side first. If we do the lengthened side first, or the relative lengthened side, then the patient may have some difficulty in the interim period. So, two criterion is more painful and the shorter side. That's what I would take into account.
So a lot of these patients have windswept deformities. So one side is adducted, the other side is abducted.
Yeah, so we should do the abducted side first, because otherwise the abducted side you can't position. So
absolutely. So two very, very important points, that you've got to do the symptomatic side first if you're doing unilateral cases, and you've got to do the abducted side first. Otherwise, if you position the abducted side on, if you do the adducted side first, you might fracture the abducted one. Okay, so any choice of acetabular components? Can I come back to Vijay?
Yeah, I think, You can use any acetabular component. We have used the non-porous ones. We have been using Trilogy or a Duralock also. And now they are young patients, so it's better, as Vijay both told, that use a normal non-porous coated cup. However, if you are having any doubts over the osteoporosis, or you should have a porous coated cup as a backup, I need to say.
So just as a consensus general question to all faculty, does your choice of cup change now, or you would do any standard cup? Anu?
So I would do what works best in my hands. That I do every day for my acetabular side, and I would use a highly cross-linked poly in this case, though I do use ceramic on ceramic. But in these cases with spinopelvic issues, I would choose a highly cross-linked poly. And of course, I'll put a couple of screws, even if my fixation is good, because a lot of these patients have osteopenia. They have not been walking for a very long time.
Absolutely. So they are very stiff. They've got a lot of newborn, but they are still osteopenic because there's a lot of disuse. Osteoporosis. Any consideration for strength of abductors? So when you look at an X-ray, would you be worried about the abductors of the hip, and would that change your choice of implant at any point in time?
Not really. Abductors have, sorry.
Dr. Abhay, just put a view of X-ray after asking the question.
Yeah, actually, I'm just realizing that if I have to do that, I'll have to go back a lot of slides. So I should have put the slide here, but I'm just banking on the experience of the faculty too. These are general questions that you need to answer in the pre-op planning. Yeah. So can we?
The only time where we are interested is previously operated cases. Otherwise, we are not interested in the strength of the abductors from a clinical standpoint.
Absolutely. So that actually is not a problem, except for the very severely deformed proximal femurs, where you might be worried about the strength of the abductor. So in those situations, would you like to change the cup to anything else, like a dual mobility, or would you go with the standard cup?
No, Abhay, the deformity has got nothing to do with the abductors. It is only the previous surgeon who can damage it. In a pristine hip, it's not been operated earlier, irrespective of deformity. You have to do releases, of course, but you don't have to do the strength of the abductor is not an issue in non-operated cases.
Okay. So effect of spinopelvic balance and cup placement. Vijay, can I come back to you?
So, most, just to make it very simple, most of these angstbond have a kyphosis, right? So, most of them, the cup is more, the native cup is more the native acetabulum is more antiverted. So, you need to decrease
very important
acetabulum, the antiversion of the acetabulum in angstbond, mostly.
See, you're decreasing the antiversion in the acetabulum. Yeah. So, a small question. So you're trying to put your hip into the Levenick safe zone. Would you be happy just doing that, or now is there consensus to look at something else? Anup, any take on that?
Yeah, so there's been a lot of debate. There's been a lot of debate on the Levenick safe zone, and when Larry Dorr, investigated the dislocated hips, a lot of them were.
Okay, so I welcome you all once again, and Dr. Rahul will speak today on the topic injuries, how to manage. Yes, Dr. Rahul, please continue.
Very good morning to everyone here on this platform. Very good morning to my respected seniors, fellow panelists, and all the delegates who are attending this new initiative of going online with this ROSACON. So we'll start something on what is known as tibial spine eversion fractures and how we deal it arthroscopically. As we all know that tibial eminence fractures or the eversion fractures are one of the commonest fractures that are seen or encountered in the children between the age group of 8 to 15 years. These are basically the variants of cruciate injuries that was first documented by Ponsett in 1895. Mayer and McKeever were the first who elaborated the surgical management of such kind of fractures. Mostly these injuries in younger individuals are sports related, and they form about 2 to 5% of all the knee injuries that are encountered. The incidence is definitely gradually increasing to 3 to 1 per 1 lakh children per year, since the inclination towards sports related activities and looking forward as a career is increasing. In adults also, we can encounter such kind of injuries, but that is relatively due to high velocity trauma. Now, what is the mechanism that is behind these kind of injuries? It's almost similar to the intrasubstance ACL tears, that is an hyperextension force with a valgus and rotational component come into force, and that causes instability and the fractures. Since the children have got more of the unossified tibial plateau, so that usually get avulsed with the bone fragment instead of the mid-substance tear of ACL whenever a tensile load is applied. One thing to recognize here is that before any bony failure, there might be an in situ stretch of the ligament itself that might even cause a little bit of clinical laxity despite we have reduced the fracture to the basic extent. So coming on to the surgical aspect, we should define the anatomy of the proximal tibia first. How this eminence actually looks like. We are going to see over this picture that between both the meniscus, there is a footprint of ACL anteriorly just behind the intermeniscal ligament around the attachment of the anterior root of the lateral meniscus. Commonly, it is seen that ACL avulsion injuries are associated with root tears of the medial or the lateral meniscus, specifically the posterior part. Looking onto the attachments of ACL in a sagittal plane, we can see this fan-shaped structure arising from the anterior tibial spine and getting attached to the posterior lateral aspect of the lateral tibial condyle. So this picture shows the inclination of fibers when the knee is in full extension, and the other one is showing when both the fibers are crisscrossing each other at 90 degrees of flexion. So how do we define or how do we classify these kind of avulsion fractures? The type 1 fractures are the undisplaced one. Type 2 are minimally displaced with an anterior beaking. That means the posterior hinge is intact. Type 3 is completely displaced kind of fractures that can be subdivided into type 3A and type B depending on rotational instability along with that. And type 4s are the comminuted anterior tibial spine fracture. Why do we need to intervene in these kind of fractures? Because we all know that anterior cruciate ligament along with its attachments is very much responsible to provide stability in the sagittal plane along with rotational stability. So if the fracture is more of an undisplaced or type 1 fracture, they can well be treated conservatively by immobilizing in extension. Rest of all the fractures which are displaced, they need to be surgically treated because most of them may have an intermeniscal ligament entrapment. If they get malunited or non-united, patient will be having a residual flexion deformity, and by that he may or she may have a significant of instability that may cause a hindrance to her day-to-day activities. So the surgery can be contemplated by either an open method or it can be done arthroscopically. The latest trends goes more in favor of arthroscopic, and we have got number of publications for that suppose that arthroscopically is well better. The various methods of fixation that can be used can be through interfragmentary screws, it can be through suture materials. Some people used to do encirclage wire for those fractures by an open method, or they can even be stapled. If we go and look about some of these x-rays that were basically the traditional methods of fixation, we can see a couple of screws that is used to fix this kind of fracture with an open epiphysis, which were kept short of physis to prevent the physeal injury. The other shows more of a staple kind of fixation. The third one is encirclage, and the fourth one is isolated cancellous screw. But in most of these, it was an open surgical procedure. Besides that, there was a bit of hardware prominence intra-articularly that causes resisted or restricted movements. And as we have seen that the fixation was not secured enough so that early mobilization or early rehab can be done, that otherwise add to the more of post-operative stiffness. Then comes the arthroscopic boon, in which we don't keep any kind of intra-articular devices, and using a pull-through transosseous suture techniques can be fixed over the tibial surface, anteromedial tibial surface, either with the help of these kind of discs or the tibial posts. Now, it has been proven with the literature that arthroscopic related surgeries are much better as compared to open surgeries, both in terms of stability as well as kind of fixation and the complications. Similarly, there was a study in St. Paul's Institute that shows that arthroscopically treated fixations were much better, specifically with fiber wires that helps in early rehab. So I'm going to present you a case right now. He's a 16-year-old male. He suffered an injury due to a fall from bicycle and has presented to us about a week later. He was treated somewhere else in the periphery with a cylindrical slab, but since he was having severe pain, he came to us. When we examined him, there was a lot of effusion all around. The Latchman was positive. Range of motion was extremely painful, but his distal neurovascular was completely intact. So this was the pre-operative picture we can see.
Dr. Rahul.
Okay. Yes, sir.
You are left with only 1 minute. I'm sorry. Yeah.
Okay. So we can see this tibial eminence fracture with a parrot beak appearance. This was his MRI that shows elevated fragment with a lax ACL. And this is how we continued with that. The surgical procedure started with thorough lavage to remove all the hemarthrosis inside. A diagnostic knee arthroscopy was done to remove all the fat pad all around, as well as it was debrided. The fracture base was delineated and it was cleared of all the debris. The footprint or the base was cleared enough to keep the fracture reduced. The fracture site was prepared with the help of shavers. A diagnostic knee arthroscopy was done to remove all the fat pad all around, as well as first we started on making a tibial.
Again, using the vicarial sutures. And sequelae to it, 6 months follow-up MRI shows weld heat, chondral and osteochondral tissues. So in all, when there is a major impaction fracture, minor impaction, I suggest not to do anything, just treat it conservatively. But if it is a major impaction osteochondral injury, say for example in this, there is a major impaction and the whole lateral condyle is depressed. In that case, I recommend to elevate it. It's a small video. I'll just take 1 minute and I'm finishing. So what I do is, I do a mini arthrotomy. I elevate the whole osteochondral piece, keeping myself around 1.5 centimeter away from the articular surface. I elevate the whole piece and make it congruent with the original, with its original position. And then I put a small sliver of osteochondral graft at the place where I have, from where I have pushed it. And this is the video you can see. Pre-operatively, he had lots of pseudo laxity on the lateral side, but now the lateral compartment is stabilized. So in all, friends, my take-home message is, try to recreate underlying mechanism before planning to fix osteochondral fracture. Treat biomechanics first. If it is an ACL injury, treat ACL first. If it is a recurrent patellar dislocation, do MPFL reconstruction first. Then try to manage the osteochondral piece. Small impaction fracture, do conservative. Large impaction osteochondral fracture, elevate and bone grafting. Small osteochondral loose body, discard it. Large osteochondral loose body, fix it. Any device is good. If you're good with screws or if you're good with Herbert screw, that is fine. But beware of complication of your fixation device. If you're using metal or plastic inside the joint, try to remove it as early as possible. Thank you very much. Kuldeep, your mic is mute. Kuldeep, unmute your mic.
Thank you, sir. Thank you, sir, for a very nice and elaborative talk of your one of the favorite topic. Now I call Dr. Dinshaw again for his, I think, best close to heart topic, ACL with meniscus injuries.
Deepak, you'll have to stop your screen share. Thanks.
Did it, dear. Did it.
Yeah. Thank you very much for this invitation. I'm going to take a lecture on ACL with meniscus tears. So you've got this 21-year-old male who comes to you now with a 3-day-old right knee injury during football. He's got a painful knee, he's got restricted range, and clinically when you examine him, he's got an ACL which is grade 3 with a locked knee. You're going to get an MRI done, and when you get an MRI done, you note that that's his ACL tear there. So he's got a complete tear of the ACL. He's got a tear of the medial meniscus peripherally. He's got a tear of the lateral meniscus where you can't see any of that lateral meniscus here in the posterior part. And in fact, it's torn and flipped into the gutter. So this is a radial transection with a peripheral longitudinal part which is flipped. Seen better out here in the actual view where we see that flipped part in the gutter. So the question for all of us surgeons when we get such a patient who has an ACL with a displaced lateral meniscus tear and a medial meniscus tear is the treatment principles. What are we going to do? When are we going to do this? Why are we going to do this? And how are we going to do this? So let's answer each of these questions very, very quickly. So what should we do? I think you need to do an arthroscopic ACL reconstruction with a meniscus repair. Why do we need to do this? Well, we'll come to that in the third question. When? It should be done relatively early. Why are we trying to do this relatively early? And that relatively early means about the 1 or 2 week mark, because your meniscus, which is displaced out, will start contracting, and it will be difficult to get a good meniscus repair after 3 or 4 weeks in this scenario. So if you've got an isolated ACL, you may treat it conservatively. You may plan to do it after 6 weeks, 2 months, 6 months. If you've got a stable meniscus tear, again, you can delay it because you're going to decrease your chances of arthropfibrosis with a delayed surgery. But if you've got a bad meniscus tear with the presence of an ACL tear, I think you need to do it early because your key out here is getting meniscal healing. And the faster you do it, the better. You don't want to do it in the first week because the knee is going to be painful and acute. You want to delay it, do it in the second or the third week. I think that's the optimal time. Why should we do this procedure? Well, if you leave a young patient with an ACL deficient knee and a displaced meniscus, as it is, he's going to have a terrible outcome. He's going to be unstable and he's going to be left with a meniscus deficient knee. Should we do a partial meniscectomy? No, you certainly shouldn't, because if you take out the meniscus on the lateral compartment in such a young patient, he's going to land up with very significant degenerative changes very early and will be very symptomatic. So that's why the only way to restore anatomy and function in this young sportsman is with a reconstruction of the ACL and repair of the meniscus. How do we do this? Well, this video will show you the same. So this is the right knee. Arthroscopically, we are visualizing from the anterolateral portal. That's the ACL. So the first thing you want to do is try and determine what's the state of the ACL. Is there any possibility of you repairing it? Is there any possibility of you using a remnant to try and augment it? Well, this one's completely shattered. So this one, no point in leaving any of that there. There's no femoral remnant. This big stump out here that's completely shattered needs to come out. So step number 1 is getting out that stump of the ACL. And typically, I'm going to take out as much as is unstable, but I will leave some of this tibial stump that it may help in the proprioception or it may help in the healing because of the vascularization which comes from there. I then go to the lateral compartment and I take out whatever clot is there and I try and identify my lateral meniscus tear. So that's the lateral femoral condyle. That's the small stump there of the meniscus. We can see no meniscus here at all. Now, no meniscus here because this meniscus is torn and flipped into the lateral gutter. I don't take out all of the clot, but I want to see my peripheral edges because to achieve a repair, I need to see this area really well. I then go into the gutter and see this flipped, torn portion of the lateral meniscus here. This is something that I'm going to need to bring into the joint. So reduce that first. How do you do that? Well, you can keep your suction open, get a hold on the meniscus and get it into position, or you can also do this with the probe. So once I've reduced that meniscus into position, I'm going to go and have a good look at it, try and identify it like you would do for any fracture, and try and see how are you going to achieve a repair in this case. So you've got a peripheral tear here. So that's your popliteus hiatus. Till the popliteus hiatus, the body is okay, but you've got a peripheral tear there, and you've got a radial transection here, and this part is also at the posterior horn unstable. And then go to the medial meniscus, and this is my medial meniscus tear. So I've got a peripheral longitudinal tear of the medial meniscus here, which you can see really well, but this is a nice stable tear, and this too needs to be repaired. So what's my sequence of doing these three? Well, the first thing I'm going to do is take my femoral tunnel, because I need to go into hyperflexion for this, and I don't want to do my repair and then go into hyperflexion. It may break my sutures. So I first do the femoral tunnel of the ACL. So I've put my over-the-top jig there. I finish off with my endobutton drill bit, and then I create the socket. So this patient, the graft is 8.5. So this is an 8.5 that I've taken up to 35 millimeters. So I've created my femoral socket under hyperflexion. I then put my knee at 90 degrees and clear off all of this tissue. Now note where the femoral tunnel is. It's within the AM bundle of the footprint, and it's as posterior as possible. I then go for my medial meniscus repair. So my medial meniscus repair I'm going to do with a fast fix, all inside sort of repair. This will be two sutures, one simple suture on the superior surface and one simple suture on the inferior surface. So I take both the sutures, and then once I've taken both the sutures, I'm going to tighten them. And when you tighten these, be a little careful, put your probe there as a device to make sure that your sutures don't cut through. So I've tightened both my sutures here for my meniscus repair, cut that off, and I've achieved a good medial meniscus repair. I'll probe it just to make sure it's nice and stable and that it's holding on really well. I can't lift it up much, so I've got a nice stable repair there. I'll then go for my lateral meniscus repair. Now the lateral meniscus repair, you're going to require quite a complex repair, because you're going to have to do two end-to-end sutures for the radial component, and then besides that, you're going to have to use 2 or 3 fast fix for the longitudinal component. So all of these need to be sutured back, and you can see what I've managed to achieve out there. So that's my entire lateral meniscus. I've got the longitudinal component fixed with the fast fix there, peripherally superior part, one more in the inferior part, and this stabilizes and takes care of the lateral meniscus here. After that, I've taken 2 end-to-end sutures out here, which take care of the radial part. And then finally, one fast fix here, which takes care of the longitudinal part at the posterior horn. The root itself is intact. So I've got a nice continuity of the lateral meniscus. I will then take my tibial tunnel, and my tibial tunnel being completed, I will then pass my graft. So this is a quadruple semi-T graft of 8.5 being passed. It's fixed with the endo button on the femoral side and a bioabsorbable screw on the tibial side. I give tension at 30 degrees, cycle the knee, and then fix it. And this is my ACL reconstruction. So I've got a nice taut ACL now, a little bit of the stump, which I've retained out here, so that this can help with the vascularity in the healing. It's nice and taut. And once I've checked that my graft is good, my repair for the meniscus is already done, all I need to do is check for extension. No impingement, and that completes the procedure. The patient then goes ahead, does his rehab, and at about the 6 to 8 month mark, we would normally get an MRI done for this. So of course, the ACL has healed really well. The ACL tends to heal really well in its tunnels by about the 4th month. The medial meniscus also looks nice and stable, looks healed here. We can really never comment on an MRI where things look so good. But most importantly, the lateral meniscus. So you can see we've got good continuity of that lateral meniscus now. That's the radial component which was torn. You remember, you couldn't see any meniscus out here at all. That's a nice healed meniscus. Both parts of the radial part are healed. And the peripheral component here also is healed. So you've got a nice ACL reconstruction with a healed medial and lateral meniscus. You've restored anatomy, you've restored the function to that knee, and this is the best way, in my opinion, to treat it for a young patient. So those are the treatment principles for an ACL with a meniscus tear. What do we do, when we do it, why we do it, and how we do it? Thank you.
Thank you, Dr. Dinshaw. One question to you. While tensioning your ACL after repairing medial and lateral meniscus, how do you tension your ACL before fixing tibia?
Okay, so what I would normally do is my graft, of course, has undergone pre-tensioning on the graft master board, but we do know that as soon as you take it off the graft master board, within 30 seconds, the creep will come in. So you always need to do a pre-tensioning after that. So I cycle the knee 20 times. Now remember, the cycling that you do for a patient in whom you've already done a meniscus repair is don't go beyond 90 degrees. So your cycling is from 0 to 90, 0 to 90, 20 times. You've got a nice taut graft, and then at 30 degrees of knee flexion, I'd go ahead and fix it with the maximum manual traction that I'm giving.
Thank you. So we should start. Any questions? I don't have any questions right now.
Chances of arthrofibrosis after doing an acute ACL reconstruction in acute knee?
Absolutely. So that's a great question. So I think that's the whole debate right now. So if you've got an isolated ACL, I would certainly suggest wait for at least 3 weeks, 6 weeks, 8 weeks. If you've got a meniscus tear like this and you wait beyond 3 weeks, your chance of getting good healing is gone. So now your options are two. You either do just a meniscus repair and don't do your ACL, but we know that if we do that, we may not allow the meniscus to heal. So you have to take that little bit of a risk and go ahead and do an ACL reconstruction with a meniscus repair in that one stage. If this patient had a collateral, then I would certainly suggest don't do it, because then your arthrofibrosis chances jump up to almost 25% from 10%. So I think choosing the right patient is important. Young male who's an athlete, who's going to do supervised rehab, is going to be your best chance of not landing up with arthrofibrosis.
True.
I have a comment for Rahul's presentation about the ACL avulsions, especially in cases when you've gone a little, let's say, slightly chronic ACL avulsion presenting to you. He talked about that the ACL stretches out before getting avulsed. So at that point, I would like to suggest that at that point, evaluating the MRI very, very carefully to look for the homogeneity of the signal on the ACL is very important to ensure that it is functional, and then you go ahead and fix your ACL avulsion. I also have a question for Deepak sir. Dr. Deepak, can I ask you the question? Yeah. So this is regarding the fixation of the osteochondral fragments. Do you advise putting in a fibrin glue around the borders to prevent the synovial fluid from getting in and improving your healing rates?
Definitely no, because it looks like a very curious question, but remember our old orthopedic fixation things. Did we ever put glue around plate fixation or anything? When you are making the fracture surface raw, and when you are fixing it with plate or suture or anything, and when you release the tourniquet, there is already blood oozing out from the fracture surface, and it is already sealing it. It's that blood that oozes out carries lots of factors that helps in fracture healing or chondral healing. So I don't think there is any need of any glue or anything. Try to be more natural and more supportive of nature, and I think it does wonders. So no glue.
One point. Yes, Sachin?
Yes, sir. Go ahead, sir. Please.
One point Dr. Deepak Goyal has mentioned, and I would like to re-emphasize that is very important, that while lifting the impacted osteochondral fractures of femur and tibia, we should have at least good subchondral bone stock. We should not lift them from the just below the cartilage. Rather, we should keep more of the subchondral bone and lift it from the intact side. That prevents healing, and that prevents the cartilage vascularity and the cartilage healthiness also. So we will take the panel discussion now.
Kuldeep, my question to Dinshaw sir is there.
Yes.
In continuation to your question about tensioning of the graft. So, Dinshaw sir, what is your take over using a flexible loop over the femoral side, flexible endo button, so that you can even tension it later if you feel a little bit of laxity while you are probing the graft, despite of all the tibial tightening you have done. And you need not go for more of repeated cycles of tensioning also in that. So what is your take?
So I think that an adjustable loop on the femoral side is a great idea and gives you the advantage that if you've got a slightly lax graft after your tibial fixation, you can go ahead and do your final tightening there. But remember that anything which is adjustable loop is always going to have some chance of a late displacement. And that's the disadvantage of it. So you might have tightened it really well at that point, but it's based on certain fixation points which may slowly become loose over time. And some studies have shown that some of these become loose up to 5 to 8 millimeters. 5 to 8 millimeters will mean that your whole ACL will be, grade 3 lax again. So I think I prefer a closed loop. A closed loop has less chances of late displacement. So whatever you achieve on table is what you get. As always, there are advantages and disadvantages with every system, and you need to choose what works best for you.
Thank you, Dr. Shaw. We should take the panel discussion, and we are having two interesting cases. One is for patellar instability by Dr. Saurabh, and another is cruciate with collateral injury by Dr. Dinshaw.
Okay, so we have some time constraints, so I'll try to be slightly fast. Okay, second, adjustable loops usually have a Chinese knot, and we should not rely these Chinese things. It's coming or not? Okay, can you see it? Hello?
Yes, we can see it, sir.
Yeah, okay, sir. So today I'll be discussing a simple case of recurrent patellar dislocation. Because we have less time, so it will be less of a theoretical part. But before we are operating or we are managing any recurrent patellar instability, we should know the basic causes of recurrent patellar instability. They are broadly divided into osseous and a soft tissue part. So it's a small history. 16-year-old female. She had a history of recurrent falls and a pain in the right knee. First episode was 1 year back, and it was during dancing. So after that, she had 3 episodes till date. And one episode was she was just coming out of bus when she was coming out of bus, and she had a locked knee. It was actually patellar subluxation, and latest was 3 weeks back. But there is no history of trauma and no history of past surgery or no significant history of injury. So clinically what we see was the apprehension test and patellar displacement were positive. So next what we go for x-rays. So these are x-rays, bilateral standing x-rays, and on the right side we can see patella is slightly towards the lateral side, but on the lateral x-ray we could not see those classical signs of trochlear dysplasia. Scanogram we have not done because I was not suspecting anything like valgus knee or kind of thing. So next thing what we have gone for was MR scans. So MR scans, what we usually do is we get the TGTT distance, so which was 18, that is marginal in this case, and trochlear depth, which was around 4 mm, which is slightly more than 3 mm, so which we consider normal. So it was not a case of a trochlear dysplasia. Sulcus angle was around 138, and insal salvati was 1.4. So it was slightly on a higher side. This is a kind of a report which we usually prepare, and the other things what we see usually in MR is the bone contusions. These are patellar displacement bone contusion on the patellar side and chondral femoral sides. And another thing, what we see usually is what more important from MR is chondral injuries or chondral defects. So now next comes the surgical management, because it was three dislocations. So there are a number of procedures, but what we decided was MPFL reconstruction. But in MPFL reconstruction, now again there are many techniques which are described. There are many techniques. One, Dr. Deepak is with us, so he has he usually is he loves to do superficial quad technique. Then there are basket weave techniques. There are many techniques, but what we usually do is just a simple we harvested the CMT graft. We marked we harvested the CMT graft, and I see there's some we harvested the CMT graft. We made a incision over the medial border of the patella. We did I think now video is not running. Earlier it was running. We prepared this gutter. We prepare this gutter from the medial edge of the patella towards the femoral condyle. हाँ नहीं अभी तो रहने दो 2 मिनट रुको 5 मिनट it's not okay. So then sorry, I'll be slightly fast because they are asking to close it now. Okay, so then we prepare the medial border of the patella. We put one anchor, 3.5 mm anchor at the upper 1/3, at the margin of upper 1/3 and lower 2/3. Then we tie a graft directly with it using a knot with the same anchor. We use a single anchor because in Indian females, patella is very slow. We use a single anchor. We use this whip stitches and we go to the upper border of the patella. And finally, it is a final picture like this. So we have a graft with a single anchor, double loaded anchor, and it is covering from middle 2/3 to lower upper 2/3 or part of the patella. Then we take the Scottish point. So we use a bead pin technique. In a bead pin technique, we use 2 pins. One is along the border of the posterior cortical margin, and one along the Blumensath lines. And this is our point of entrance. We can also use a device from the Arthrex, which is more convenient. But I'm very happy with the bead pin technique, and we pass it through it and fix it at the 30 degree of flexion. We usually put one coccus below the graft so that we don't make it too tight. Otherwise, too tight graft will also be a problem. So this is movie. This is before fixation, and the second one is after fixation. We can see that now it's going into the groove. We are seeing it from the superior lateral portal. So take-home message is evaluation and the treatment of patella instability continues to evolve. There are many things which will come. Thorough physical examination and accurate diagnosis are the key. Surgery we need to direct along the underlying pathology. There is no role of isolated lateral release, which the literature shows to us. And MPFL reconstruction is a choice of recurrent instability with or without cochlear dysplasia. And distal alignment is done when TG-TG distance is more than 20 or patella alta.
Thank you, Dr. Saurabh. Yeah. A nice presentation. Now, I will request Dr. Dinshaw for his next case on ACL with collateral injury.
Okay, good morning, everybody, and welcome to the pelvis session. So today's session, I'm Dr. Abhay Allens, and I am at Indian Institute of Medical Sciences at Jodhpur. And today's session is very special because we are going to be dealing with simple acetabular fractures, and the cases that we have for the audience is posterior wall fractures. And the theme is difficult situations in simple fracture management. So it's going to be a very challenging and a very good 40 minutes for us. So before we go ahead, I would like to introduce our chairpersons, very senior members of our fraternity, Dr. Vinay Goel, who's a joint replacement and an excellent trauma surgeon based out of Jaipur. So welcome, sir. Dr. Kishore Raichandani, who is the ex-professor and head of the Department of Orthopeadics at the SN Medical College at Jodhpur. Another very, very accomplished trauma and a joint surgeon. So, and we also welcome Dr. Salanki, who is a very senior surgeon in Jaipur, and he's based out of, and he essentially is a joint surgeon. So, just handing over to you, Dr. Vinay, Dr. Kishore, for a quick word before I introduce the faculty.
Thank you very much, Abhay. It has been very kind of you that you have invited us to be the chairman, and you have called all the galaxy of the faculty from UK, from Jaipur, and all around, and we have organized such a lovely session. And I'm sure this is going to be very fruitful and very good for the young and experienced surgeon as well. And we will have the knowledge which we will gain from the people from UK, Dr. Nikhil, who has come specially from UK. So you will introduce all of the faculty from where and what they are doing and how good they are and where are they doing in pelvis fractures. So over to you again, Dr. Abhay.
Thank you so much, Kishore sir. Dr. Vinay sir, a quick word from you. Dr. Vinay sir.
I think his internet has frozen.
Okay, so we'll wait for Dr. Vinay to come back online. He's back. Dr. Vinay sir, a quick word from you.
Yeah, am I audible?
Yes, very audible. Please go ahead.
Okay, so welcome you all, and I hope this will be a good session. And I ask Abhay to welcome all delegates and to start the session.
Thank you so much, sir. Just to let us know, we have 112 participants in Hall A for the pelvis session, which is a great number. And we have a galaxy of excellent faculty. We have Dr. Nikhil Shah, who works at Wrightington Hospital, the Mecca of hip surgery in the UK. And Nikhil is a very, very accomplished hip surgeon and a pelvic surgeon and a great friend. We have Dr. Pradeep Nimade, who is an assistant professor of orthopedics at KEM Hospital, Mumbai. A brilliant trauma surgeon and a very good shoulder scopy surgeon and a brilliant organizer. And he's a wizard with IT. So welcome, Pradeep. And we have our own masters, Dr. Umesh Meena, who's an associate professor of orthopedics at the SMS Hospital at Jaipur and a very, very accomplished pelvic surgeon. Welcome, Umesh. And we have Dr. Sandeep Kumar, who is a young and upcoming pelvic surgeon, also based out of Jaipur at the Mahatma Gandhi Institute of Medical Sciences in Jaipur. So welcome all of you. And the way we have structured this is that we are going to be having 3 cases. If there is time, we will have more. So we will start with Dr. Pradeep Nimade, and his case is going to be a redo surgery in a posterior wall fracture. So over to you, Dr. Pradeep. Pradeep, आपका screen.
Thank you, sir. Thank you, Rajasthan Orthopeadic Society, for inviting me for this August meeting. First time in India we are seeing an online conference, and it's looking spectacular. So today we're going to discuss a case, and it's more of an interactive discussion among the panelists and all the people on the dais. And this is a case. It's a 23-year-old male, and now he is staying in a very remote area of Maharashtra. If you know, it's on the MP border, a place called Gondia, the Adivasi area kind of a stuff. And then he suffered an acetabular fracture, and he presented to the district place at around 3 weeks post-trauma. I have put a question mark there because that is the history that is given by the patient, and we'll soon know how the history can sometimes be deceiving. And this is the X-ray he presented to my friend, and who is a very good paleo-acetabular surgeon. Just to tell, he presented on 11th of Jan 2020, and this is the X-ray with which he presented. He was dislocated like that. These are his CT scan. Now we can see, if we can see from the posterior aspect and from the medial aspect, we can see a fracture line going like this. From the posterior, we can see that the entire posterior wall has come off, and but however, the obturator ring is looking intact. Another CT projection. Here we can see that the entire posterior wall of the acetabulum, along with a very sizable portion of the ischial tuberosity, going just near the ischial spine, is going off from there. And here also we can see that almost it is going into the insertion of the TAL, and the entire posterior lip has gone off. So it is just short of a column. So you can see why we are not calling it a column, because the posterior, the obturator foramen is looking intact. And that's why the ischial continuity is maintained with the rest of the acetabulum, and that's why this is falling into the domain of posterior wall. And these are the CT scan. If you can see, though the hip is dislocated, we can see that it is nicely congruently articulating with that postero-inferior portion of the posterior wall. So as to say that when it is getting dislocated, it has carried that wall along with it. So generally, when we see a dislocation, we see a dislocation in a posterior superior wall articulating here. In this case, we are seeing exactly opposite, that it is dislocated and it is carrying the posterior-inferior wall along with it. And that's the CT scan at the level of acetabulum. Again, we can see that portion is now nicely articulating with here, and there are few interarticular pieces as well. And if you see the classification again of this fracture, we can say that sorry for that image is not showing here. It's a posterior-inferior fracture here, and it is a very massive extended posterior wall, because it is almost going into the obturator foramen. So it is a very extended and a massive posterior wall fracture, and which is a posterior-inferior type of a posterior wall fracture. So the primary surgery, any takers for this now, sir? Just to start a panel discussion here. What would be the line?
So just quickly go to Nikhil. Okay. What will you do in the first row? Because our basic focus is the problem that we have come across.
So I think this is a delayed presentation of an extended posterior wall. Even though the head of the femur is partly articulating with the articular surface, this is not an acceptable position. And I think this would need a proper formal open reduction and internal fixation of the posterior wall. I'd like to see the axial images a bit more in detail to see if there is any superior marginal impaction. I think probably in the most there is no obvious marginal impaction. There is some loss of cartilage. The long-term prognosis may well be guarded in this case, but I think it still deserves a proper open reduction and internal fixation.
Yeah. So as rightly said by Dr. Nikhil Shah, so that's what the plan. And my friend, again, he undertook this case, and he planned a surgery which was done on 21st of Jan 2020. KL approach was taken. Now I had a long discussion with him after the surgery, and then what he told me that he had a difficulty in the surgery in the way that he was just not able to get that head down. He's just not able to reduce that head, and when he tried to see the head from down from the fracture side, he could see that the head is well articulating. So he thought that the head is reduced, because as I say now, here we can see that it is articulating here. So if it is not getting down, one may falsely assume that it is already in, and that's why I'm not able to reduce it any further. And I think that is what is the thing that was perceived at that time. And again, sometimes patient give improper history. To his surprise, he could see that entire fragment, the inferior fragment, was almost solidified, and he had some trouble in mobilizing that. And ultimately, this was the picture he could get. and he tried little bit taking the iliofemoral approach and trying to go from that side to go and see for the superior fragments. Again, that can be debated. That was not required, but yes, that sometimes when you struggle and everybody has a bad day, we can try to do, we tend to try to explore much more and more. So anyway, this was the picture at the end of the surgery, and the next day when he sent me the picture, this was the picture. So
we have the panelists' opinion on this. Maybe Dr. Umesh can opine. What do you perceive of this X-ray?
Looking at this, I think hip is not in sternum. Probably because of one reason is that non-reduction, the inappropriate reduction of that posterior inferior part, and also maybe there is presence of intra pieces. So probably it was a delayed case, and when you seeing the axial cuts, you can see that there is a fragment which is stuck in between the posterior inferior and intact ilium. So probably that was the reason for irreducibility of that posterior inferior part. So I think it requires revision for me. I will go with the same approach, and will look inside that what will be the reason for that. Probably that fragment between the posterior inferior part and the intact ilium, that was the reason for irreducibility.
Yeah,
I think probably the posterior inferior fragment has already malunited.
Yeah,
it might be long. It might be longer than 3 weeks. So I think to reduce this, you have to literally take down the fracture with an osteotome, or like do an osteotomy, mobilize it completely, bring it into the correct position, and only then I think the hip will come down.
Absolutely. I think I agree, because the X-rays that we saw, the CT that we showed earlier, the medial part of the posterior inferior fragment was not completely broken, even though it was off the foramen. But unless we complete that osteotomy of the posterior inferior fragment and put it back completely into the ischial tuberosity where it belongs, I think the head will not reduce, because as Dr. Pradeep's friend also complained that his perception was that he thought the hip was reducing, but it was actually not reducing. So I think it is the partially broken posterior inferior fragment which is the key factor in not allowing a reduction.
So at this point, let me ask all the panelists, what would be their indication, or rather, what would be their contraindication for a redo surgery? Because this X-ray is begging for a redo, but which are the scenarios in which they would not rather do and redo?
Infection, infection or wound problems.
Yeah, infection and wound problems, or again, a poor bone stock or old patient again may not be more suitable for a redo surgery, and maybe a proper reconstructive surgery in form of replacement may be a alternative option. But in 23 years, we have no option but to go ahead and do a repeat surgery and redo fixation. As far as assessment planning, timing is as early as possible. As far as assessment and planning is concerned, I think one of the most important thing, and I was pretty lucky in this case, is to discuss with the primary surgeon.
Yes.
If that is possible, many times patient will just come to you. You don't know the primary surgeon, or you are not very not in a good position to speak with the primary surgeon. But in this case, if you know the primary surgeon, you can discuss very frankly with the primary surgeon.
Repeated
what
CT
has
scan
happened.
to look also rule out.
Yeah, repeat a CT scan. Yes, so we can repeat the CT scan. So in this case, again, the CT scan was not repeated, just primarily because I thought there was not much of a reduction, and it was looking the same again. Again, the patient was in a very remote area. So again, I have not repeated it, but yes, we can definitely do a repeat CT scan, and we need to know what are the issues with primary surgery, if any. Like this, in this case, we know that my friend, he couldn't just get the head down. And we know that is the main thing where he has struggled. And when we are trying to go in, we should have all the plan in our head as what to do, so as we don't face the same problem again. And goal of the surgery again may has to be realistic. Many a times primary surgery and secondary surgery, the goal of the surgery may not be the same. So in this case, reduction of the hip, the head into the joint, and reconstruction of the posterior wall was the main goal. of the surgery. And we must discuss the limitation and acceptability with the patient. And again, as Dr. Nikhil Shah told, the expectation has to be realistic. The prognosis may be guarded. So in this case, again, a redo surgery was done by KL approach. A little bit more liberal incision was taken. I took a little bit time to develop the original planes because I don't want to damage the vascularity any further. And I was so lucky again that the primary surgery was done by the proper pelvic surgeon. So he has taken proper care so as to divide the rotators around 2 centimeter medial to the insertion, and so as to the vascularity, so whatever vascularity was not damaged during the surgery. Implant removal was done.
Just a short reminder, Pradeep, we're already 10 minutes into the conversation. We have 2 minutes more for this.
Okay. So in this case, we can see that this is the main problem, the stenosis of the path where the head is going to come down. So in a fresh case, this moves. You can just retract this part and the head goes down. When this is stuck, you just cannot give the traction and head will never come down until unless we mobilize this fragment down. And so this path is stenosed here, head, no way the head can go down. So in this case, osteotomy was done as suggested by Dr. Nikhil Shah. I took the osteotomy medial lateral side. Little bit of quadratus was removed from the ischial side. We took the osteotomy, and just the entire fragment was completely osteotomized from all the side. Capsulotomy was done from the acetabular side again. Complete all interarticular fragment were removed, and the entire fragment, this fragment was completely turned down just based on the hamstring attachment. Just when we did that, the entire hip become loose, and then we can reduce the hip, and then it was fixed with 2 plate, one plate for the posterior inferior fragment, another for the smaller fragment. And this was the X-ray at the end of after the surgery. We can see little bit small fragment flying over there, but most of the posterior wall is well reconstructed. And this is around follow-up at around 25th of May. So this is when last time the patient had come to this thing, little bit HO occurring there because of the repeated surgery, but the head is well congruent. I'm sorry for the poor quality X-ray because that is what has been sent to me on WhatsApp. However, the patient is started full weight bearing and right now is having no pain and going around very well right now. But finger crossed, because we know repeat surgery, long duration of dislocation, the patient may land up in AVN or some kind of post-traumatic arthrosis. But at least we are in a better position in case that happened to salvage, to reconstruct that hip had it been left alone just like that.
So great job, Pradeep. So can I ask one of the faculty to just summarize the take home for the audience before we move on to the next one? Maybe Nikhil can do it for us.
I think in delayed situations, the most important thing to understand is unless the big wall pieces go into their anatomic location, the femoral head does not follow. And you should be prepared to do an osteotomy of the extended posterior wall. Sometimes the ischial spine also, if the column is involved, take it down completely. So you have to reduce that, and then the femoral head will follow that.
Yeah, so very, very important points in a very great case, excellent execution, and an enumeration of the take-home messages. So if there is, would you like to add something, Dr. Pradeep, or can we move on to
no,
the
I
next
just
case?
displayed it. We can move on to the next case.
Okay, great.
Thank you
so
very much.
Can I request Dr. Umesh to show his screen? So we're starting at 11:59, and I think we have 10 minutes for this one. So we plan to finish by 12:10.
My screen is visible now?
Yeah, very visible.
Yes. Thank you, Dr. Abhay. So after a wonderful case of fracture dislocation by Dr. Pradeep, I am going to present a simple case, but a delayed presentation. So my case was also a young male, which was having high with crush injury foot and also chest injury. So initially he was treated at a tertiary care center. His knee was reduced and applied a transarticular fixation and with some plastic intervention. But he presented to me after a 10-week period. At that time, he was unable to stand and having pain in the hip. So for that, he was evaluated radiologically and found he was having a posterior wall fracture with maybe a column fracture. So for that, I have evaluated him radiologically and found that he was having extended posterior wall with two main pieces. On 2D evaluation, it was found that he is having a comminuted posterior wall with some intra-articular pieces in situ. So what should we plan now? Dr. Abhay? So
so can we go back to the slide? Can we go back to the X-ray? Yeah.
Okay.
Yeah. So this is a okay. The CT will do.
So these are 3D.
Yeah. So there are two important things here. One is that not only is there a superolateral posterior superior fragment of the posterior wall. The second thing is that there is comminution and there is a posterior inferior fragment as well. The head is dislocating out, and there is a possibility of a marginal impaction here, which I would like to see, because what I can see of the wall, it is turning around. So there is a possibility of marginal impaction. And the other thing I would like to see is that if there is any intra-articular fragment left behind. So the three things which are important to my, which are concerning me here is, one is a comminution, second is an extended posterior wall, third is marginal impaction. So I would like to reduce the head, reconstruct the marginal impaction if required, put back the comminuted posterior wall and buttress them with spring plates, and then I would put a long posterior column plate, to take off the shear stresses of the fixation. And if I can, I would put in raft screws as well as lag screws to the wall fragments.
Thank you, Dr. Abhay. So exactly, there was intra-articular pieces also there. So anybody in favor of reconstruction with primary replacement?
Patient is very young. I think you should try and save the hip.
Okay.
What is the timeline up to when we can operate and try to fix the acetabulum? I mean, like 3 months old, can we go on till what time?
There is no timeline for that. If it seems reconstructible and patient is quite young, then we can go for reconstruction. And we can make a solid wall that is helpful in future totally. So I have done up to 1 year.
Yeah. So it has been shown that the vessel that is in the obturator externus, that maintains the vascularity even in a dislocated position. And if we try to explore and we can drill the head, we can try to see whether the head is vascular. And even if the patient develops a post-traumatic arthrosis, somehow the post-traumatic arthrosis is a little bit well tolerated than otherwise idiopathic AVN that we try to get. So in any scenario, 30-year-old, we should try to reconstruct and not replace.
Correct. I agree.
Okay.
Yeah,
so
very well said.
I have gone through the same plan. So I have discussed with the patient and decided to go for hip salvage and posterior acetabular wall reconstruction. So anybody can enumerate about the tips and tricks for reconstruction? Dr. Sandeep? That what about the approach, position, what about the preservation of vascularity, need of any strut graft, role of any trochanteric flip osteotomy? Dr. Sandeep is there? Dr. Pradeep?
I think here in any delayed presentation, I think one of the most important thing has the most liberal exposure. We should not try to, otherwise we have a tendency to expose just what is needed. But here, two things. Number one, that we need to assess the pathoanatomy completely, and we need to again release those fragments, and so as to keep the neurovascular structure also intact. So in that case, it's always better to have complete exposure. If required, GT osteotomy may also be kept handy. And again, for vascularity, we don't release the capsule from the fragment in posterior wall. I did in last case, but that was an inevitable situation. In such small flakes of this thing, we should not release the capsule, because if we release the capsule from the flakes, it will become avascular.
Yes, that is very important. So I have gone through the same plan. I did it in KL approach in lateral position. GT osteotomy was done deliberately, which helps in exploration and clearing of joint space. It also helps in reduction in these old cases and we can also check the quality of reduction directly from inside. So after exposure, I found that there were two major pieces. Piece one was posterior superiorly, which was rotated around 90 degree, and the another piece was, that is number 2, which was completely rotated 180 degree and toward the greater sciatic nerve. So I have mobilized the both pieces, preserved the vascularity of piece 1, but I failed to preserve the vascularity of second piece, which was removed completely, and after reduction, put it back again and fixed with the K wires. So after temporary fixation, I check it under C-arm, and which was, I found that reduction was satisfactory. I put few leg screws and a long recon plate was applied. And this was his immediate post-op X-ray. Anybody want to add this, that there could be a chances of improvement, anything better can be done?
So Dr. Sandeep is back. We can have a comment from Dr. Sandeep, and then we can go to Dr. Nikhil.
You want to add anything that better can be done for this case? Any role of two plates?
I think that's the intraoperative judgment. Means on post-op we cannot comment. If the surgeon finds on table that at one plate is sufficient, I think just on looking the X-ray we cannot say that. Sometimes the surgeon may want to put 2 plates, but that is intraoperative decision.
Yeah, that is all depends upon the entrop, your stability, your type of fixation, and the size of the pieces. So I have done it with single plate. After putting few leg screws, fixation of osteotomy was done with 3 fully threaded screws. So what are the things that should be remembered post-operatively? Any specific about the post-operative protocol in these cases? Dr. Sandeep?
I think Dr. Sandeep is not with us right now.
Yeah. Dr. Nikhil, you want to say something about the post-operative protocol of these cases?
Yeah, I would keep them protected weight bearing, so non-weight bearing. We tend to use indomethacin to prevent heterotopic ossification. Whether it works or not is debatable, but it makes the surgeon feel good. I personally would not use traction if your fixation is good enough. Like Pradeep said, if the whole purpose is to get the patient mobilized early and start movement in the hip, then I don't personally like traction. We use continuous passive motion for the first 48 hours, and after that get the patient out of bed, and then full weight bearing generally between 2 and 3 months.
Thank you.
Umesh sir?
Yes.
Can I ask one thing? Actually, this is a posterior wall along with the posterior column fracture. So,
if you are going to see the CT scan, it was an extended posterior wall. There was no posterior column fractures.
Okay. Still, I think there is 2 big chunk of the posterior wall. So the at least 2 plates should be applied, and the plate position should be as lateral as possible to prevent the further dislocation and to give it more stability.
Okay. But actually, the thing was that after fixation of the 2 posterior wall fragments with leg screws, I found it sufficient that 1 plate was enough for me. But yes, if the fragments are large enough, there is comminution, we can apply 2 plates also.
And the position of the plate should be as lateral as possible.
Yeah, the column plate should be towards the greater sciatic notch, and the wall plate should be towards the edge of the wall.
It is always a balance between using enough fixation and not too much fixation. If you have to apply second plate, you have to dissect it much more. You have to get underneath the gluteus maximus all the way to the superior gluteal artery. And I think if your lag screw is giving good fixation, 1 plate is more than adequate.
Absolutely. I think at the end of the fixation, again, we can just try to very guarded internal rotation. If the posterior lip is remaining fixed in that position, I don't think so it required. So Dr. Abhay would remember we were doing one case
live.
Just at the end, I was doing live, I fixed everything, and just when I did internal rotation, the entire fixation was started to falling apart. And then in that situation, we have to go ahead and fix with the another plate.
Correct.
So I followed the same protocol. I kept him non-weight bearing. No DVT prophylaxis was given. because it was young, I have mobilized him on bed. HO prophylaxis in form of mendomethacin was given. I am scary about these cases about as we ask the patient to do rest, they start walking. They said that just I have go for washroom. So I applied a skin traction deliberately.
Okay.
And abduction was avoided for initial 6 weeks. Then progressive physiotherapy and weight bearing was started. And this is his recent of 18 months. There is no AVN, no HO. He's doing fine. So the take-home message is that we should do adequate clinical and radiological evaluation all polytrauma cases. We should always try to do reconstruction in delayed cases whenever it's feasible, particularly in young patients. And while doing reconstruction, we should try to preserve the vascularity. And of course, the GT osteotomy is of great help in these old cases. And even though the results are not always encouraging, but after reconstruction, later replacement becomes a quite an easy job.
Yes.
Thank you so much, Dr. Umesh. And we are on time. And we have 13 minutes for the next case, which is Nikhil's case. And I think that will be the last case. So over to you, Nikhil.
So I can't yet share my screen.
Yeah, so you can now start sharing your screen. Yeah.
Can you see the screen now?
Yes, we can.
Yes.
You need to put it on. Yeah. It has to be on slideshow mode.
Yeah. Is that better?
Yeah.
Okay, so the theme is difficult situation in simple fractures. So this is a 65-year-old male patient with osteoporosis. He has had a trivial fall and he has dislocated his right hip joint. You can see that the femoral head is also fractured, which is the typical finding in dislocations. So under normal circumstances, there are two strategies for these kind of cases. You would do a closed reduction in the beginning as an emergency treatment, and then some surgeons would prefer to fix this fracture because the femoral head fracture is located inferiorly and the weight-bearing dome appears to be reasonable. Some surgeons might want to consider a fix and replace philosophy, and they might want to do a joint replacement at this stage. So this is usually a simple bread and butter type of case for most orthopedic surgeons. But then what happens? So this is his CT scan. You can see that there is some marginal impaction, but it's a reconstructible fracture. Unfortunately, on the third day, he gets a massive bilateral saddle embolus involving both his pulmonary arteries. And we then find out that he was not on prophylactic anticoagulation. So at this stage, how do we manage it? So it's a simple situation, but now it has become a bit more complicated because of a pulmonary embolism in a 65-year-old male patient. So what do you think, Pradeep? What would you do?
So I think here multimodal management is very important because management of this medical condition, as I would say, a secondary medical condition needs involvement of specialist, probably the pulmonologist or the hematologist. And according to their guidelines, we need to treat the pulmonary embolism. As far as the posterior lip or posterior column fracture is concerned, I have a policy of delaying. I can delay it as much as 3 to 4 weeks, because we know that till 3 to 4 weeks we can still address this fracture very well without having much of the secondary issues in that. So after doing this discussion, we can take a decision whether as to do IVC filter and do early surgery, or we want to wait.
Okay, so our philosophy is that if there is a documented proximal vein thrombus or if there is documented pulmonary embolism, then the risk of dislodging that embolism during surgery and during manipulation is high. So after discussing with our respiratory physicians and with our hematologist, he was put on therapeutic anticoagulation with low molecular weight heparin, and then we put an IVC filter through the femoral root. After that, it takes some time before you can get a stable situation with your therapeutic anticoagulation. You have to titrate it very carefully until the patient is stable. This patient was referred to us a little bit late, and he came to us finally for surgery at 6 weeks. And at that time, when I went in, I found that the posterior wall had become a thin shell and had basically disintegrated, and there was a big posterior wall defect. So at this stage, how do we deal with it? Umesh?
Yeah. So you have managed pulmonary embolism and patient is stable. Now we are going to focus on that reconstruction of posterior wall, and considering the duration, patient age, and head damage, I think I will go for simultaneous total hip with posterior wall reconstruction. And if I found it inadequate, I will use head as a graft, strut graft, to reconstruct the posterior wall and do it. I think looking at the quality, I will go for uncemented one.
Uncemented. What about you, Pradeep?
Oh, I think though its patient is at 60, around 60, we need to see how young physiologically he is, and if it is, if we take a decision of salvaging this hip, I think there are articles. Dr. Sen has published an article where we can take iliac graft and we can reconstruct this posterior wall. And I think for a 60-year-old man, that will still do. If we can just reconstruct a wall and fix it, we may be able to buy a few more years. However, if the patient is not that physiologically young, I think preoperative discussion with the patient needs to be done so as to take a decision of converting it to total hip during the surgery.
Okay. Remember, his bones were osteoporotic and he had a femoral head fracture as well.
Yeah, so in that case, it's much more going towards total hip.
Yeah, so that's what I did as well. Like Dr. Umesh has said, I use the femoral head as a graft, and you fashion the host bone, you fashion the femoral head, you provisionally fix the graft with some K wires, and then I like to buttress it with a plate additionally. If your bone graft is predominantly superior, then it is loaded in compression. But if it is posterior and superior, then the shear forces are quite high. So even if the column is not fractured, I like to put a plate on the bone graft to buttress it down, and then additional screws through the bone graft to get you better rotational stability. And then you ream it so that you can then create almost like a new acetabulum. So in this case, if there is a single big piece, I don't mind going for cemented sockets. You can get very good drill holes and integration of the cement. So I've gone for a cemented socket and performed a fully cemented total hip replacement. I think most of the pelvic faculty know that I predominantly use cemented hips.
Can I ask you one question on this? One slide back. Yeah. So as to fix this fracture with these screws, regarding putting these screws, means do you put the screws before you start the reaming, or you just originally fix with K wires and then complete the reaming and then you put the screws?
Always before the reaming, because the reaming can cause a lot of torque on the fragment. And if it keeps torquing the fragment, then sometimes in soft bone, the fragment can splinter or shear, or it can pull off the entire fixation. So I like to have an absolutely solid fixation. And then we do something called as the patient shake test. So basically you grasp the bone graft in your thumb and your index finger, and you shake it vigorously. And the whole patient and the whole table moves rather than the graft, and it doesn't pull off. It's subjective, but it gives you an idea of how solid it should be before you can prepare it. And this is the follow-up at 7 years. And if you look at the 7-year follow-up...
comment to that, Nikhil?
Yes?
Just the previous slide. So another thing which we have been doing is that once we fix the fragment onto the wall, whether posterior or posterior superior, and buttress it with a plate, we leave scope for additional fixation of one proximal and one distal screws once we've finished the reaming and the total hip. When you're tightening the hip, we just probably leave a space for one additional screw proximally and distally, just so as to make sure that the fixation is secure and we've not got any loosening during the process of the hip.
Of course. It's a fine balance, because if you look at the size of this fragment, if I put a third screw into it, the fragment will probably splinter.
Yeah, so the fragment probably will take only 2 screws, but maybe the plate might take an additional one. Yeah, but we can even put 1 screw and then do the hip and then put the next.
Correct. So, whatever works best in your hands.
Yeah.
And this is the follow-up at 7 years. So he's had a very good functional result. So what is the take-home message that we want to convey? it's important to use VT prophylaxis, and certainly in this part of the world, it is routine to start a low molecular weight heparin on the first day or the first 24 hours after the patient is admitted to you, as soon as you achieve hemodynamic stability if it is a pelvic fracture. So we start within the first 24 hours and we tend to give it for 6 weeks. If the patient has a confirmed thrombus or if there is a pulmonary embolism before you can get to surgery, then we have a low indication, a low threshold for putting an IVC filter. These IVC filters have to be removed at 6 to 8 weeks. So in this case, we had used what is called as a Cook Select filter. Then they get therapeutic anticoagulation, and you have to give them an appointment for removal of the filter at about 6 to 8 weeks. If the filter stays in for longer than that, then it can be problematic because the filter then ingrows into the inferior vena cava, and then it is very difficult to remove it, and then they need lifelong anticoagulation. Also, if a filter, once it is integrated into the vessel, and if it gets infected, it can cause an infected aneurysm of the IVC or even of the aorta. I have seen one case, and that can be fatal.
Yeah, so can we just, now we have about 3 or 4 minutes remaining with us. So can we just take the opinion of the panel on when, how many of us would use the IVC filter and what kind of a filter and what protocol would you use? So can I start with Dr. Umesh? So do you use an IVC filter? And if you do, what are your indications for an IVC filter and what kind? Dr. Umesh, are you there?
Yeah. Hello.
Dr. Umesh, are you there?
Yeah.
So do you use an IVC filter? And if yes, what is your indication for an IVC filter?
Frankly speaking, I have never used this. But whatever I heard and I found that whenever there is a DVT, which is proven, we can use IVC filter before surgery. And after doing that surgery, we can remove it later after, I think, 6 to 12 weeks.
Dr. Sandeep?
Sir, I have never used in not yet, not in pelvis tubular surgery. But one case of chondrosarcoma pelvis we did. In that patient, there was femoral vein thrombosis. So we have applied it the IVC filter before surgery, and later on it was removed after 8 weeks.
Dr. Pradeep?
Yeah, so it's definitely not my decision, in at least in the center where I work, where it is to put the IVC filter on. As soon as the patient has some amount of some confirmation that the patient is having DVT, straight away the hematologist and these people come into picture, and that is their decision. So I'm little bit blessed that I don't have to take that difficult decision whether to put the IVC filter or not. So and I have not tried to dwell into the depth as to what are the types of filters and which should be used or not, because I'm not the one who takes that decision.
So agreed. If I can just offer a few statements on this, we do use IVC filters, and the indications for using IVC filters are very clear. One, if you have a proximal thrombus, which is either a femoral vein or an iliac vein thrombus, then, and if you have a surgery which you need to do, then you need to put in an IVC filter so that you prevent further embolism. Second, if the patient has a history of a venous thromboembolism or has already had a thromboembolism, which is often the case, then you need to put in an IVC filter to protect for further emboli to go into the lungs. The third is if you are in a situation where, according to the OTA risk assessment profile, the patient is a high risk, but you cannot give adequate thromboprophylaxis for some reason, whether they have a head injury or they have other issues of bleeding or polytrauma, then those are the situations where you need to put an IVC filter. And as Nikhil very correctly mentioned, they use the Cook filter, but basically the filter to use as of today is a removable filter. We do not use permanent filters, and the filter has to be there for about the safest time to take it off is between 4 and 6 weeks, because you leave it longer than that, there are issues of filter-induced thrombogenesis and other issues as well. And your thromboprophylaxis through the surgery has to continue till such time you have removed the filter. and maybe up to 3 to 6 months of some kind of prophylaxis along with mechanical prophylaxis for the patient. So do you have anything to add on this, Nikhil?
No, that's my indication as well. So if the anticoagulation is delayed beyond the first 24 to 48 hours, then we do a screening ultrasound. The screening ultrasound does miss proximal thrombosis, so often I insist on a venogram, and if there is a thrombus, I will put a filter. If there is no thrombus, if it's absolutely clear, then it's a case of discussion of the risks and benefits with the patient. But if you have a confirmed negative thrombus at 48 hours despite not giving anticoagulation, then you have to discuss, because then the risks of the filter might outweigh any potential benefits.
Absolutely. Okay, so thank you all. It's been a wonderful discussion. So just to summarize the session, I think we've had a session on predominantly posterior wall fractures, where there have been difficulties of reduction, there have been difficulties of delayed presentation, difficulties of different opinions with the delayed presentation, the possibility of a redo surgery and why you should do a redo surgery and what are the indications of doing a redo surgery versus doing a replacement. And we've had a case where because of the age, because of the quality of bone, because of the marginal impaction, we've done a redo surgery and then the kind of surgery or a replacement you need to do. So excellent session, and I would like to thank my panelists for a brilliant discussion. And over to you, the chair, to finish off the session.
Yeah, on behalf of ROSA, let me thank each one of you for a wonderful presentation. It's nice to see my alumnus who is working in KM, and so many nice words spoken about him. So congratulations, Dr. Pradeep. And nice to see Nikhil Shah after a very, very long time from Mumbai. So, and very nice to see he's working in a very premium institute which has a lot of history in the hip replacement surgery. So thank you one and all for a wonderful session. And we wish to see you more on such web conferences in future. Thank you all.
Thank you so much.
Thank you.
I am Dr. Rahul Garg, moderator for the shoulder trauma session. It has been a very busy morning on Sunday of 12th. Dr. Rahul Katta and Dr. Rajesh Goyal Sahab and all our ROSACON team has taken a great effort to start this first of its kind virtual meeting. And I think without going much into the details, pleasantries, I would welcome all the panelists. First of all, I would love to welcome Rakesh Bhargav sir, our chairman of the session. Welcome sir. Rahul Katta and Dr. Rajesh Goyal Sahab and all our next galaxy of panelists and speakers. Main star of the faculty, Dr. Ashish Babulkar, senior consultant director at Junaid Mangeshkar Hospital at Pune. He is president of the Elbow Society, director of FNB Sports Medicine and Training Center, and founder director of Shoulder Conclave, which is a biennial meeting which is famous all through the world now, and not only country. He is a pioneer in reverse shoulder surgery, and he is another pioneer for open lateral jet procedures, arthroscopic lateral jet, AC, joint biological implant-free reconstructions. He is avid marathon runner, advanced scuba diver, and accomplished calisthenics, calligraphy, everything. I don't have anything left out, which is to be introduced about Dr. Ashish sir. Another faculty, we have Dr. Pratik Goyal as a consultant from Santokba Durlabji. Dr. Hemant Jain, morning everybody, professor at HNMC Jodhpur, Medical College Jodhpur. I have Dr. Mohan Mantri sir, who is another panelist. He is the director of the Akanksha Orthopeadic Center, senior orthopedic surgeon from Kota. Dr. Prashant Modi, associate professor at famous Medical College Jaipur. Dr. Nitish Gehlot, another of the panelists, assistant professor at AIIMS Jodhpur. Dr. Naveen Sharma, senior consultant at Jaipur, orthopedic surgeon, private practitioner. Dr. Abhishek Gupta, another upcoming young budding orthopedic surgeon at Jaipur. So I think Dr. Saurabh is here as a technical support and shoulder guy with us, and we'll take the meeting. And I think I would love to start with first presenter, Dr. Pratik, to go ahead and start his first case. You can start sharing your screen, Pratik.
Good morning, sir. Good morning, everybody. I just share my screen, sir. Can you see, sir?
Yeah.
Yes. Yes.
You can start your slideshow.
Yeah. Good morning, everyone. I thank everybody to have trust and given me this opportunity. I welcome and thank all seniors and colleagues. So I hereby start with a clinical case of the proximal humerus fracture. And this is a 65 years old male, diabetic and hypertensive, had a fall at home and sustained injury to his left shoulder. All the sign and clinical symptoms of proximal humerus fractures were present, and this is his X-ray. So AP and lateral views in emergency that day, negative X-ray. So I just, as it's a question here, will like to ask the panel what next we want to do.
Proceed. I think
how to proceed.
Prashant can enlighten us. Dr. Prashant, please.
Prashant.
You can unmute yourself, Dr. Prashant. You are muted. You can unmute yourself.
Can you please post up the X-ray? Post the X-ray again?
Yeah.
So this seems to be a fracture of valgus impacted fractures, and there seems to be a 4-part fracture with a tuberosity, greater tuberosity moved proximally and posteriorly.
Yeah.
And the lesser tuberosity.
Yeah.
This is basically a valgus impacted 4-part fracture of the proximal humerus.
Absolutely. Anyone else?
I think
Naveen.
Dr. Naveen.
Yeah, I think Dr. Prashant is more or less summarized the thing. I would, if you require a further investigation, I think a 3D CT can further give us a better information about the orientation of the fracture and about the comminution of the fracture fragments.
So, okay. So, anyone want to give his inputs, or should I proceed with the?
So I would like to add one thing, sir. This is although impacted fracture, but the angle, the head, neck, and head shaft angle is almost 180. You can see the articular surface is straight ahead. So CT definitely will help. This is highly displaced, and we can expect a lot of cancerous bone loss in the head while operating this case.
Yeah, correct.
So I would like to add one thing.
Dr. Mohan Mantri would like to add something.
Yeah, any comment about the osteoporosis? I want to say. We're more concerned with the treatment point of view.
You can see the articular surface is straight ahead. So CT definitely will help. This is highly displaced, and we can expect a lot of cancerous bone loss in the head while operating this case.
Correct.
I would like to add one thing.
Dr. Mohan Mantri would like to add something.
Yeah, I have added. I am concerned with the osteoporosis of the bone.
Right, sir.
Yeah.
We can go ahead. Next slide, please.
Okay. So next this is one CT picture. I've taken a small video, which is
3D video,
360-degree view of the video of the CT. That is 3D. So you are correct. This is a valgus impaction fracture with both the tuberosities and the head with displaced, and alignment is also, as Nitesh was correct, it's almost 180-degree angle between shaft and the head. So, which is so Prashant, what you would like to do next?
I would like to give a surgical option to this patient because the tuberosity are wider apart, and leaving this will lead to great loss of shoulder function. So I'll use a deltopectoral approach and try to open book this tuberosity and try to disengage this fragment in the normal anatomical alignment, and then try to close the tuberosity over the fracture and fix with the Philo's plate with additional fixation of the heavy suture to both the tuberosity and fix it to the plate.
So Rahul sir, please take input from some other, because
I think, Dr. Mantri would like to say something.
Yeah, just I agree with the Modi, but only one thing which I want, that definitely you need a reduction of the tuberosity, but the head part should be handled with minimum handling should be done for the head part.
Okay, sir.
To prevent avascular necrosis of the head.
Okay. Dr. Naveen? Sir, Ashish sir. Yeah.
Pratik, just one tip. These are intra-articular fractures, so CT scan should be done always. The one tip from my side is that when a 3D CT is done, you must request the radiologist to do a subtraction film. So they will subtract the glenoid, which is uninvolved, and then you will see the medial unfaced view of the head humerus. Sometimes the split head fractures get missed, and you go in and you find that there are issues there. So
you're right.
Here the 3D CT with subtraction views is far more appropriate.
Sir, as far as the risk of AVN is there, this is a valgus impaction fracture. So compared to virus, I think how do you rate the possibility of AVN is lesser in these cases? And what are your tips to reduce this head over this shaft? How do you suggest? What do you suggest?
I think the risks for AVN are high if there's a fractured dislocation. If there's a 4-part fracture, then it's not so high. The AVN in humerus is not as bad as proximal femur. We tend to derive a lot of our information from the femur, but they revascularize very well. So I'm not too concerned as long as we go in quickly and do an anatomic fixation. Compared to the varus, the valgus fracture will be reasonably okay to reduce, and the risks of going into varus are much lesser, more tolerant. You can fix it in valgus, and it's still safer to do that. Like Dr. Mantri said, we tend not to expose the fracture fragments. We don't cut the subscap. Leave the entire soft tissue envelope intact, and just do an indirect reduction. So in a varus fracture, you need to correct it with a flat periosteum and just lift the head up. Whereas in a valgus, mere traction in a fresh fracture is good enough. And once you've got your restoration of neck shaft angle, just put a vertical K-wire from the top going down into the shaft. Then you've got a maintained position. But the key results and the success of function, because everybody is looking at union. Union is achieved anyway. Nature does it. Our orthopedic surgeon has no credit in achieving union.
Correct.
But the ability to achieve this function is by management of the greater tuberosity.
Correct.
If you can get the tuberosity anatomical, fix it, usually by sutures, never use wires, you will get a very good function then.
Right. Perfect.
I think you can go ahead.
So, thank you. Hemant, sir.
Yeah.
Okay, next slide.
I just wanted to just...
Yes,
Hemant. 2 points. You just talked about AVN. So the good point here in this case that medial hinge is preserved. So that is good point, which is if it is disrupted, then it favors AVN in such cases.
Correct.
Hemant, I don't agree with that.
Why, sir?
The paper by Ralph Hertel for the medial hinge preservation suggested that there should be at least a centimeter on the humeral side.
Yeah, metaphyseal. That is,
so you need a metaphyseal spike. So you need a 1 to 2 centimeter metaphyseal spike.
Yes, sir.
Then the chances
there are 2 points. One is metaphyseal spike. Other is medial contact between the head and the metaphysis. So that is, I think, is preserved in this case. Not more than 2 millimeter displacement. That is good point.
Correct.
Yes, Nitesh want to say something.
Dr. Ashish, I just want your view. In such fractures, there is a lot of combination and loss of cancellous bone inside the head. So when we are fixing with the upper loss, although we have locking screws, but we find it difficult to reduce because there is a hollow shell. So what are your views on primary bone grafting in such cases? Or some people use fibula also in such type of cases. What are your views and how much are those helpful?
Nitish, these are all osteoporotic fractures, and the biggest challenge is the CT looks good, it's state of the art, but nothing will tell us the quality of the bone. And the worry is that if somebody has some systemic metabolic disease and that head is an eggshell, then you are in deep trouble because whatever imported lock plate you use, it's not going to hold. So we have to be prepared. Whenever there's a 4-part elderly, diabetic, you've got enough comorbidities. I always keep a prosthesis on the side. You never know. If your fixation is not good, your purchase is not good, there's nothing you can do about it. Till date, I have not bone grafted a single fresh 4-part fracture.
Yeah.
Because
that is right.
union is not a challenge. In proximal humerus, vascularity and union is not a challenge. You just have to align them in good position. The fibula graft is not easy. It doesn't go in well. And you have to split the fibula. The shaft will not take it well. And there are bigger challenges when it fails. So I use it for non-unions where there's a varus and bone loss. Because the fibular graft will singularly prevent progressive varus. In a valgus fracture, the chances of that happening are very less. So I'm not too worried about that.
What is the age of this patient?
65.
So, Dr. Babalkar, sir, you just suggested that you would keep a prosthesis by the side. Would it be a simple hemi, or would you keep a reverse shoulder prosthesis by your side in a case like this? A 65-year-old male with a...
One input I want to give. He is a hard-working villager. Okay, when he fell down, he was 65 years old, but physiologically he was very strong, and he was a hard-working laborer and used to peasant farmer and does all routine and strenuous activities of his life. So physiologically, he is strong.
Right.
So I agree, Abhishek. It's the physiological age that is important.
Yes.
Not the chronological age.
That's why. So maybe you would keep a hemi alongside. Right?
Yeah.
Next slide, please.
Next, so I just want to do what we did. I usually prefer when there is a displacement of greater tuberosity, I usually prefer the anterolateral or deltoid splitting approach myself. This is my personal choice, and then we exposed through this RAF and isolated the nerve and reached the fracture fragment. This is the head is well seated like a golf that thing, and this is a small video. I reduce the head. It was a strong head. Bone quality was very good. I used a lot of force to lift it. So this way we lifted it, and this is the view of the tuberosity, greater tuberosity. Through this approach, we could have a great view of the tuberosity because it displaces superiorly and posteriorly. So we just caught hold and that brought it to the position, because as Ashish has said, reduction is the key. You have to align the fracture fragments properly, and after that we reduced and fixed with the temporary K-wires, caught hold of all the sutures which were through the tuberosities and the cuff, and fixed it with a Philos plate. And these are various techniques of...
This is an anterolateral approach or a deltopectoral one?
I use the anterolateral deltoid splitting one.
So do you expose the axillary nerve during your dissection?
It has to be. Deltoid splitting, it is always exposed.
Yes. So are we able to see the axillary nerve here?
Yeah, you want to see? I just go back. Yeah, this is the axillary nerve I've taken in the tape, right?
Okay.
Can you see? Okay.
Yeah. So one of the important points that I would like to bring in at this point is when you do a deltoid splitting kind of an approach or a lateral approach, the axillary nerve, if you are planning to put screws, if it's a kind of a MIPO kind of approach, you'll not be able to put more than the 6 top screws, because the axillary nerve will come in the way of putting the calcar screws. So if you are doing such an approach, the anterolateral, you should ideally expose the axillary nerve. You should dose up periostally, putting the plate there so that you do not injure the axillary nerve.
Definitely. It is almost always, it needs to be exposed, because we have to just take control of the nerve gently and then put our screws, but it always comes on the way of the few screws. Okay. So this is after fixation, and so this is just, I calculated the angle. It was normal was 130 to 40. It is all road 195 degree angle. And after surgery, I could manage to get 135 degree. And this is post-op. And this is video on table. I tried to manipulate. A few clinicals, sir. This is one of the overhead. Sure. And this
done. Quite good, Pratik.
Pratik, only one thing. Did you edit because for the reduction of the GT? Usually, I prefer putting in a suture in first in rotator cuff and then bring it down rather than holding it a bone piece, because in osteoporotic bone it get in a tear into the bone segment and bone become fragmented.
Sir, I always take control of the tuberosity through the ethibond through the rotator cuff, sir, because that way, and after that later on I tie every suture. See, you can see these sutures are through these holes. I put the plate, and then over the plate we have to tie the sutures so that it fixes nicely, sir.
Right.
Only one question, Ashish. Would you go for the anterolateral or you will go to the deltopectoral approach?
मेरी और एक्सेल नर्व की बनती नहीं है. So I am a big proponent of deltopectoral approach. My question, my consideration here is that there is a 10% incidence of axial nerve injury. There's a very interesting paper come out last year from Germany. Even if one patient gets axial nerve palsy, I think it's burning all bridges as such. So it requires great skill to expose axial nerve, ensure that it is there and it doesn't have friction with screws. What Pratik has shown is very nice, ideal. In my hands, the deltopectoral works. It's extensile. The concern is for approaching greater tuberosity. With the instruments that I have no challenge in reaching the greater tuberosity. We end up putting it very nicely. So there's no unmet need for me. That's fine.
Okay, agree.
Dr. Ashish, one small question. Apart from four-part fracture, if we get a calcar fracture also along with this, how do you address that calcar fracture? Because the calcar part doesn't allow perfect angle. We get a perfect angle.
So you mean in a combination?
Yeah, in a combination, in a calcar combination.
Yeah. So
what
that is challenging.
We can do?
So what we try to do is, unlike here, my job is never to expose the fracture. I keep all the fracture biology intact. And so we prefer to do indirect reduction all the time. When there's a calcar fracture, then what you need to do is just take a centimeter or 2 centimeters of the pec major off. And you're allowed to do that. There is no disability with that. And that allows you to go medially and expose the calcar fragment, reduce that, and capture that in your first metaphyseal screw, which is a cortical screw, non-locking screw. And you can then shift the plate up and down. Once you've got that, then you can play around with the rest.
Right. Nice tip, sir.
Thank you. Dr. Babalkar, sir, you just mentioned about the first screw, which is the non-locking one. So sometimes what happens is that when you put a non-locking first screw, then it eventually sometimes displaces the actual reduction. When you see the intra-op X-rays and the post-op X-rays, so what some of the surgeons, they suggest is that the first screw that you put, the first cortical screw, it should be a locking one. And then remaining the non-locking ones can do. What is your opinion about it, sir?
Abhishek, there are many ways to skin a cat. If you take all the top 10 surgeons who fix fractures, each one does it according to your own bit. My concern is do whatever works in your hand.
No, not about the calcar. So if you have a calcar, sorry sir to interrupt. So if you have a calcar fragment, you definitely need to pull it back. In such scenario, non-locking screw would be very helpful. But if it is a regular fracture, then would you recommend a locking or a non-locking, or it would be a case-dependent kind of a situation?
Absolutely. It depends on what works in your hand. What is important is your screws should not be prominent. They should not go through the cartilage. That is a very common problem, almost 23%, and that's unpardonable because that's iatrogenic. Number two is your GT fixation is solid, always with sutures, no screws, and your neck shaft angle must be restored. If you can achieve this, your job's done.
I think we should move on to
next case here.
Dr. Hemant, kindly.
Good afternoon, everyone. I'll go straight away to my case. So we got a 51-year-old female who sustained injury to left shoulder during an accident. She slipped from her squatty. It was a closed fracture. She did not have any associated injuries or comorbidities, and neurovascular status was normal. So these are the pre-op X-rays. I have not very clear. Anybody like to comment on this, or shall I move to CT?
You
can see
no lateral view or nothing. Axial view is not there.
We see something there in the axilla, some kind of a head fragment in the axilla.
Yeah, Abhishek, you are commenting something?
There is some head fragment in the axilla anteriorly to the glenoid, anterior inferior to the glenoid.
Yeah, exactly.
There's a large fragment there. Yeah.
This is the head fragment actually.
Yeah.
It's a fresh accident? Fresh fracture?
Yeah, the patient came fresh in the afternoon. Okay. So this is the head fragment. So this is basically a fracture dislocation. I'll show you the CT films. Now it is very clear. Yeah. So comments of panelists.
I think Dr. Prashant can take. Dr. Prashant is there?
Yeah, I'm here. Am I audible?
Yeah.
Yes.
This is basically a fracture dislocation in which the head has come out from the vicinity of the glenoid and it's been in the axillary pouch. So looking at this X-ray, I don't think so this head is going to have a vascularity even after restoration, anatomical restoration. In a young patient, say, what is the age of the patient?
51 years.
51, I think salvaging this shoulder can expect a redo surgery and this may undergo avascular necrosis. So I would keep a low threshold for doing a hemi in this type of patients.
Ashish sir would like to point out any...
Anybody in favor of salvage?
I am in favor of salvage. She's 51. So we must, as far as possible, try and bring it back together. There's an excellent paper by Robinson from Edinburgh, and even before by Rockwood himself. 5 patients, fracture dislocation, 1 patient head out on the table, put back in. Amongst the 4 of the 5 patients, the posterior capsule is always intact. If those of you do hemis, you remove the head, you will see that you have to cut the posterior capsule before you excise the head completely. That has rich blood supply. So I'm not too worried about the avian. There is a high risk of avian. But again, avian is not a bogey that you would face like in the fracture neck femurs as such. So if it is possible, you get a good fixation, bone quality is good. My first attempt should be a fixation. But if you find that the head quality is poor, it is fragmented, there are cartilage changes, and there is no soft tissue attached at all, I would keep the hemi as a backup. So I'll consent them for both.
Dr. Ravulkar sir, in this scenario, in your hands, I'm sure an osteosynthesis would work excellent. But in most surgeons' cases, osteosynthesis in a fracture like this would be very difficult. And I have learned from you that a primary hemi would be a better choice. You know, if you have to operate a patient, then rather than going for an osteosynthesis, which eventually would fail, and then you keep hemi as a backup would not be a good idea. And going for a hemi primarily in a scenario would be a better idea. So am I right on this?
That statement is significantly counterfactual. Let's say another surgeon who's a non-shoulder surgeon, who's a trauma surgeon, and Babulkar. The fixation will work well in both the hands, provided it's done better, of course. But the hemi done by somebody else, the chances of it not working are very high.
Yeah.
So in a shoulder surgeon's hand, a hemi will work reasonably well, not 100%. In Europe, they have given up doing hemis because the tuberosity management is extremely challenging, skilled, and even if you do a good job, the tuberosity integration is difficult. You need a trauma stem, you need a fracture stem, you need the technology to get the tuberosity back in. You need to understand circular sutures, you need to understand knee knot, and even then nature may not favor you. So the chances that a fixation will work across the board, if you generalize all orthopedic surgeon, is much higher. A chance of a hemi going wrong in a non-shoulder surgeon's hand is significantly high, I would say.
But the problem here in our area is that the patients, the affordability is an issue, and what the surgeons they end up doing is a kind of a monoblock kind of a hemi, and that I think is the worst thing to do. Because eventually it's not like an AMD. In case of shoulder, you have to correct the version, you have to correct the height, you have to correct the lateral and posterior offset, you have to bring the tuberosities, you have to make sure. So, yeah. So
Abhishek,
it's better, sir. Yeah, you're right.
Indications for fixation.
Yeah.
because their life cost is an issue, availability is an issue. Go on, Hemant.
Yes, sir. So that's what Abhishek rightly pointed out. If we want to do a hemi, we need to a good implant also. Otherwise, it's going to have a worse results than Philos. So these are the 4 fragments we see here. And the challenges I found, basically this head fragment was very small and it had very high risk of poor fixation. And risk of AVN was almost 100% as per Ertel's criteria. Like there was medial hinge disrupted and metaphyseal extension was less than 8 millimeter, and it was fractured to anatomical neck. Still, as sir said, I kept both Philos as well as hemi on my table and decided to go ahead. So this is the trauma stem. I decided to choose. This is designed by Babulkar sir itself. So this is proximally porous coated, and distally we can do cementing. And it has got this is a flange here and the flange here, holes here for reattaching the LT and GTs. So I don't have the intra-op pictures. These are the post-op X-rays. Comments from Babulkar sir.
It's a good job, but Hemant, we always need a lateral view because the GT and the orientation and version. And like you said, in a fracture scenario, if I do a hemi, I'm usually uncemented, but in a fracture scenario, I would always do a distal cementing. Only
distal cementing,
like
exactly.
you have done. Like you have done, we keep the proximal uncemented.
These are my first hemi, so I was afraid to get an axillary view in the immediate post-op. You get it routinely in every post-op scenario.
See, the best chance of getting a good axial, your best chance is intra-op once you've done everything under the C-arm. Under the C-arm.
Exactly.
So you've got it. And then it doesn't matter. Then the next lateral would be done at 6 weeks. So I would also not do it in recovery. But when I'm in the, just before suturing, just quickly get an AP lateral done.
Exactly.
Hemant,
We should always check it under the
You have done an excellent job you have done an excellent job for a first hemi. Coming on to the version part, Dr. Babulkar sir, if you remember, we had done a study on cadavers in which was later eventually got published in the International Journal of Anatomy, and we saw that the version was from somewhere 18 degree to about 55 degrees. And the instrumentations that we have for today, the versions that they allow is about 20, 30 or 40 degree. And if you have gone through that the article by Pascal Bolo published in the Journal of Shoulder and Elbow Society, you would realize that even in his series, about 23 to 25% had failed GTs, and that was because he attributed it to the wrong version. So could you suggest us how to get this version thing right? And do you suggest that we should take the opposite shoulder CT scan to understand this? Or what exactly should we do to get the exact version, the correct version for a shoulder?
Abhishek, that paper by Pascal was a good concept, but wrong application of data. The problem, GT fractures were in above 70 patients, above 70-year-old patients. We are dealing with a 51-year-old patient. So chances of his tuberosity healing, if we have repaired it nicely and looks anatomical, nice like this, it should heal up quite well. But you must understand, the version is something that is very peculiar. You have no landmarks. So you have to ensure, do several trial versions and get it right. As such, it's difficult on this forum to go through all that because that will be quite time consuming.
Hemant, you can stop.
So we have to restore basically the humeral height. We have to correctly match the version. We have to calculate it preoperatively what is the version of the patient on the opposite side. And we have to make the tuberosities unite to get a good result in hemi. Otherwise, it is going to give us bad results. So this is the... Yes, sir.
Okay, I want to ask a question because you have to ensure good healing of the tuberosity is over. So sometimes I use the bone from the fractured head. I just curate some bone.
Definitely, we have to use the beneath. You rightly pointed out, Dr. Pradeep. Yes. When we suture back the tuberosities, we have to suture the tuberosities to the stem.
Yeah.
We have to suture the tuberosities to the shaft. And we have to suture the tuberosities to each other. And in between, whatever space is there, we fill it with the graft we get from the head, retrieved head. So this is the 3-month follow-up. We can still see a gap here in the LT. So GT looks integrated, and she had very little movements at three months, and I was quite concerned. But now it's almost 2 years follow-up. This is the 1 year follow-up X-ray. You can see the GT is well integrated. We cannot identify the GT fracture. LT seems to have resolved, only small part is seen. And these are her 2 year follow-up. Yes,
that's excellent.
Good. Excellent.
Very nice. Excellent.
I think I would like to wind up this talk. I would love to, can you stop sharing? And Dr. Ashish sir, please start your presentation, please.
Yes. I'll stop.
Internal rotation is very good, Hemant.
Yeah, thank you.
Very nice, Dr. Hemant. Very
thank you.
Dr. Ashish is going to speak about failed fellows. Stop sharing your slides.
Yeah, I'll just stop sharing. These were the tips already we have
next
discussed.
case, Hemant, you ask me to join, I will come to learn.
Yeah.
How can I? Yeah, stop sharing. Okay.
Right. Yeah. Ashish sir to start his.
Yes. Coming up. Thank you, Rahul. Thank you, ROSACON. I hope you have my presentation on the display.
Yes, sir.
Okay. So, coming up, we'll just jump into the case directly. This is the lock plate has done a disservice to us because it has just made everything very easy. And so the complication rate of lock plate remains extremely high, almost 20 to 30%. And this is one of the scenarios here. So quite clearly, I'll spare you some time and just give you all the details rather than stop it here. But this is a lady who had a fall at home, a 60-year-old lady, no comorbidities. And this is her presentation at 6 weeks. Somebody did a fixation. You can see that's day 1 failure because there is nothing anatomical there. Calcar has failed. Screws are not in the correct position. And he panicked and he freaked out and put her in an abduction brace. And that really panicked her because then she got more pain. It was difficult to maintain her arm in that position. And they realized that something is grossly wrong. And that's when she rushed in to come and see me. When she came down, we got her CT scans done, and you could clearly see that fragments were misaligned. There was inferior subluxation that is suggesting that the axillary nerve is not doing well, and the whole head started falling apart within a week of her appearing here. And there's no GT. It's gone into varus. That's obviously going to go into non-union. The cartilage is deteriorating. Worse than that is the problem here for you. So for the panelists, this is almost 6 to 7 weeks post-op. There's clearly anterior deltoid wasting. And I got her EMG studies done. Axillary nerve had poor conduction and interference, and she had extreme pain and disability. So we are dealing with a non-union. We are dealing with a axillary nerve palsy, 60-year-old lady, no comorbidities. So how do we proceed here now?
Dr. Hemant, would you like to take the lead?
Yeah. So we have 2 problems here. Basically, you said one is of non-union and implant failure, and other is nerve palsy. So
and revision, may I add?
Yeah. I'm not able to think about it. First of all, we need to remove the implant. It's causing pain to her, so we need to remove the implant. And the cartilage is already going bad, so we cannot preserve this shoulder. We need to think of terms of replacement only. And she's already 65-year-old, you said?
60,
and GT is also absorbed, so cuff is not going to function. I think we need to do reverse, but what to do about the nerve, I don't know, sir.
Somsec would be a better choice, sir.
Because if we go for muscle tendon transfers, I don't have any experience.
Sir, what about a Somsec procedure?
So Somsec in trauma is not described. SOMSAC is for an elective. In trauma, there's so much disruption, and it's going to take much longer because the SOMSAC recovery. What Abhishek means with the SOMSAC is you transfer the radial nerve from the medial head of triceps directly to the axillary nerve lateral branch, so that you don't wait for the axillary nerve branch recovery. You just innervate the muscle straight away. But it can take between 6 months to 9 months. By the time the whole head and everything assembly will collapse. Naveen?
Dr. Naveen? Does EMG also inform you whether it's a neurontomesis, like I said, breakage in the nerve, or it's like some recovery chances are there or something like that?
So at 6 weeks, the EMGs go comma sa. And of course, we've established that clinically she had reduced sensations on that side, 30%. But it was not completely gone. So it was not.
That's a good
If you
sign.
have a complete neurotmesis, there is zero trace on the EMG, then that's a brachial plexopathy. So that they will tell you. So if at 6 weeks you're getting some poor conduction, that means some of the nerve is intact.
Mantri sir, would you like to add on?
For the accelerator, I'll wait.
Okay.
Nitesh?
Yeah. So,
sir, as has been mentioned, we are dealing with multiple problems. One is the and a painful shoulder. I'm not sure what is causing the pain because the screws are still not protruding inside the joint. Definitely something must be. So we have to, I think union should not be a problem if we are going, but we will have to add some bone graft definitely, and we will have to take care of the rotator cuff, which are very important for the function. The other way of going is replacement, but because in this case, I would go towards the reverse total shoulder rather than the regular one, because greater trochanter and lesser tuberosity are of questionable status. And but deltoid weakness is there. It's only anterior deltoid weakness. So although deltoid is the basic functional muscle for reverse total shoulder, but after at 6 weeks there is partial poor conduction. Complete loss is not there on EMG. So I think that with physiotherapy and all, we can get a good function of deltoid rather than going for drastic procedures of nerve transfers and delay them for after some months if we don't get function.
Ashish sir, I think we are short of time. You can
So
summarize, please.
The point was that the axillary nerve may not have gone, but if it has gone, it's either due to the previous trauma, which the surgeon didn't pick up, and in which case most of them will recover, and that is the hope. And the surgeon was a senior trauma surgeon, although the fixation was not appropriate. The other thing was he could have damaged it during surgery. And whether you do a deltoid split or deltopectoral, it doesn't matter. The axillary nerve is vulnerable for both the approaches as such. So not only are we dealing with a very elderly lady with poor bone quality, but there's failed fixation, the bone quality is going to be poor. Don't forget revision. There's going to be immense scarring there. You will not get planes because you go in there, you can't see a deltopectoral plane, and your rough dissection will cause more bleeding, lot of scarring there. And of course, the axillary nerve is going to be right in your path probably. So we did a few things here. Clinically, I examined her. Anterior deltoid was weak for sure. You cannot examine a painful fracture patient, but you can discern by doing certain movements whether the muscle fibers are recruiting at all. So clinically, we established that the posterior deltoid seemed to have some life in it, and there were some contractions. So what we did first was did an ultrasound, and on the dynamic ultrasound asked her forward flexion, abduction, posterior movement, extension, and we could visualize muscle recruitment of the posterior and the lateral belly and zero recruitment of anterior belly. So there was a concordance between the clinical picture and the ultrasound picture. We didn't stop at that. What we also did was on physio, we stimulated the supraspinatus and the deltoid on rehab. So we use that for rehab. So we use that idea and we decided to give a stimulation. Now, when a nerve is bad or it is dysfunctional, you need a very high amount of galvanic current to stimulate the nerve. So our physiotherapist told us that the anterior deltoid would not respond to even the highest stimulation, but the posterior and the lateral deltoid were responding to about 50 microvolts. The third thing we did was during surgery, we consented her that we will explore the axillary nerve, and if it is scarred, we will explore it. We'll do a neural lysis and we'll stimulate the nerve. If it fires and I actually establish a deltoid recruitment intraoperatively by keeping the patient light on anesthesia, then we will go ahead and do the reverse for you, because your reverse will work on a posterior and lateral deltoid. But if there is zero recruitment, nerve is dead, then we'll just remove the implant and wait for the axon nerve after decompression and then consider a nerve transfer or actually a arthrodesis, which would be a final. Never put in a reverse or a hemiarthroplasty when the axon nerve is completely dysfunctional, because it will create and take her from the frying pan right into the fire straight away. So when we opened her, there was a huge amount of scar tissue around the axon nerve. We decompressed that. The moment we decompressed that, the stimulation started working and she started firing the posterior lateral deltoid. The anterior deltoid never came back. So I suspect it was because of the surgery where you put your hormones on the lateral side. Then if there's a persistent pressure for a long surgery, then the anterior branch of the axon nerve will just go off. So often when you see a lot of these lock plate fixation patients come in, their anterior deltoid is washed off completely. It's just bone there. That's probably because the anterior branch of the axon nerve has been hampered. So the bone quality was very poor, so I needed a cerclage, and we've done an uncemented fan prosthesis as Hemant has shown, and done a reverse, and we managed to have a functional range of movement restoration. You must understand this is not like a primary case, this is a salvage case, so it's not expected that she do completely normal, and this is her 3-year follow-up. And again, the GT being missed, it causes severe dysfunction, because without the GT, the rotations are going to be poor. But at least she's pain-free. She smiles at me every time she comes in on a yearly follow-up and tells me that she can now reach her hair and tie it up. So it's a decent salvage that I can say, but exceptional case. The point I would like you to learn and understand is that the first surgery should be the best surgery, but don't take lock plates lightly. The lock plate has made things very easy. Proximal humerus fractures are very difficult fractures to treat. So we must be very careful, because the complication rate remains very high with proximal humerus fixations. Thank you.
Nicely elaborated. I think I will directly go to Dr. Prashant, and he can start with neglected posterior dislocation of shoulder. Prashant, please.
Yes, sir. Yeah. I'm visible or inaudible, both? Yeah. So I'm presenting a case of a neglected lock posterior dislocation of the humerus. I'll just come to my case. This is a 48-year-old female housewife. She has a history of electric shock, and followed by which she has pain and a decreased external rotation and abduction of the right shoulder. She was managed initially at some primary care center, and initial x-rays were done, but no treatment was offered, and she presented to us after 8 weeks with this x-ray. These were the initial x-rays which were done at the district level hospital. So can anyone comment about the x-rays, the findings of the x-rays, or shall I just move ahead?
This is a light bulb sign we can see here.
Yeah.
An electric shock, commonly posterior dislocation is associated.
Yeah, this seems to be a posteriorly dislocated shoulder, and classically this is called as an inverted light bulb appearance because of the steep internal rotation. This is the X-ray at 8 weeks, which we get at our institution. You can see a hyperdense line at the medial articular surface, which is impaction fracture, also called as the double trough line sign. Also, there is an increased medial joint space, also called as the rim sign. So with this diagnosis, with these findings, would you like to do something else, another investigation or another view?
Axillary views must, Prashant. We need to have an axillary view.
Absolutely right, Dr. Abhishek.
Prashant, one more sign.
Yeah.
That this is called as a vacant glenoid sign.
Yeah, vacant glenoid sign is because of the, yeah. This is basically similar to what this is basically because of the internal rotation. The head seems to appear, the cavity seems to appear vacant. So that is also called as vacant sign. As rightly pointed out by Dr. Abhishek, axillary view is a must to confirm the diagnosis. But most of the time, these patient has a limited abduction and external rotation. So at time, axillary view is not possible many of the time. So what other investigation? I don't have any auxiliary view because that was attempted, but it was not properly.
CT scan.
CT scan would be very much
CT scan is a must in these cases. These are the axial cuts. CT scan basically shows your confirmation of the diagnosis, as well as it also gives an idea about the articular defect, because that has a bearing in your surgical treatment. So in this particular case, as you can see, this is a posterior locked fracture, posterior locked dislocation of the shoulder. And on calculation, there appears to be around a 30% articular defect. So we have a patient who is 48-year-old female, came to us at 8 weeks with a locked posterior dislocation. So what is the management?
This is 8 weeks, Prashant. 8 weeks is reasonable. You must understand that the cartilage is deteriorating very rapidly. Right. So in my experience, beyond 3 months, the cartilage usually doesn't survive. It just peels off. So, and she's young as well, 50-ish. So I have a paper published, one of our better papers on posterior dislocation. We have an algorithm on this.
Yes.
But can you see my arrow on the screen? The black arrow going around? No?
No.
Can you see this now? The white arrow?
No, sir.
No, it's not moving. There's no arrow moving, sir.
Okay,
you can come out of the full screen.
No.
Then you will be able to.
Don't worry. What I'm saying here is the critical fragment. That is the area.
I have mentioned that in one of my slides, subsequent slides.
That's the critical fragment. And this is the hill sac.
Yes.
So if you can slide your osteotomy here.
As pointed out by Dr. Babulkar, this area seems to be matching with this area. So as per Dr. Babulkar paper, this is a critical fragment type 2, where the size of the critical fragment exactly matches with the size of the defect. This corresponds roughly to 25 to 40% of the defect area. And in his paper, what he has mentioned is if this area, this tuberosity fragment is more to this area, that corresponds roughly to less than 20%, it's critical fragment type 1. And if tuberosity fragment is very small as compared to the head defect area, then it is probably type 3. Those patients, as per McLaughlin's original description, are not a good candidate for the McLaughlin procedure and are better treated by hemiarthroplasty or the salvage procedure. So with this, this is an evolving surgical algorithm. So if the area of defect is less than 25% attempt and duration of less than 6 weeks, then a closed reduction is attempted under general anesthesia. However, if it is unstable, then one can consider for the subscapularis transfer. If the area is 25 to 50%, and then one should go for the tendon transfer, either a McLaughlin's procedure or a modification of it. One can also consider the anatomical procedure like allograft and autograft reconstruction. Rotational osteotomy has also been described in the literature, but very few results, long-term results are available. And if the area of the defect is more than 50%, then serious consideration for arthroplasty should be given. However, in young patients, still we can consider for allograft and autograft reconstruction because the long-term results of hemiarthroplasty, especially in young, are not good. So we offered a surgical treatment. The patient was taken under general anesthesia. The semi-V-chair position was used. A deltopectoral approach was used. And these are the intraoperative findings. The first and the foremost structure to be identified is the long head of the biceps, because that will give you an idea about the anatomy of the distorted anatomy of the shoulder. Once that is been identified, then the rotator interval is dissected and try to lever out the shoulder by gently externally rotating. These are the intraoperative findings. Then the osteotomy will be done medial from the intertubercular groove to the lateral margin of the defect. And this is the total area. You can see in the white, in the black column, this is the osteotomy area and this is the defect area. So it exactly match. So this patient, as preoperatively assessed on the CT scan, is roughly corresponding to the 30% of the articular surface. This is the paper and this is a description by Dr. Babulkar. So now we further proceeded and we fixed that medial tuberosity we medialize the tuberosity and fill it in the defect using two cancellous screws, and we enhance our fixation by taking a transosseous suture using number 5 ethibone and locked in at the muscle tendon junction, tendon bone junction in a crisscross way. This will give a double row type of repair where this thread will prevent the ripping of the tuberosity, and simultaneously these two screws will provide adequate compression at the defect side. These are the immediate post-operative X-rays of the patient, and these are at the 5-month follow-up. You can see there is some amount of backing out of the upper screw, but tuberosity has healed very well, and patient doesn't have any hardware-related problem. So, these are her clinical photographs showing good range of motion at 2 years. And she is also able to do some amount of external rotation, which may be a limiting factor in the McLaughlин's procedure. And so these are the complications which are described for this procedure, which include recurrent instability, AVN, stiffness, non-union, chronic pain, and resorption of the graft if any allograft or autograft was used. So in conclusion, this is a rare entity, and high degree of suspicion should be kept in polytrauma patient and also in epileptics. And true X-ray including AP, and this lateral axial is a must, but sometimes it is very difficult to get these X-ray. CT scan is must to quantify any bone loss, and management is according to the duration of the injury, amount of bone loss, activity level, as well as the age of the patient. Thank you.
Very nicely done. I think, do we have time for last paper to be taken by Dr. Ashish? Dr. Saurabh, can you guide us? Webmaster, can we take another 10 minutes? I think nobody's there. Everybody's gone for lunch or what?
We can continue then.
You can stop the slides. Prashant?
We can take Dr. Ashish's case, I guess. It will be...
Okay.
Yeah.
Sure. Just give me a second and then I'll switch on. I thought this was all done. But I think excellent job, Pratik, Prashant, Hemant. I enjoyed all your cases. Very well done. This is a very good sign for the country that we are maturing so well and we are doing everything that is required to be done. Okay, so this is again to expose my clinical skills and not something that I have done in the most optimum manner. And that's why I think there's a lot more to learn from this case. 43-year-old gentleman had a fracture at a town that's almost 300 kilometers from here 6 days back. And he was admitted, and those guys worked him up quite well, did CT scans, and he was told that this is a split head fracture, and so you need to do an hemiarthroplasty. And then this fellow freaked out, and the one thing he didn't want was a hemiarthroplasty because he was from a fairly rural setup and wasn't sure what he needed. So he contacted us, sent us the images, and said that I don't want a hemiarthroplasty. And so these were his CT scans. I received this case through a lot of political pressure, and we were operating the whole day on a Saturday. So we decided we'll operate him. Already he's 6 days old, and we took him into theater directly, knowing that Monday was a holiday for some reason. So we would have lost 2 days, Sunday and Saturday, Sunday, Monday. And so we brought him in directly. So I got to see him between two cases. So there was no time to work him up, but he had already done his CT scans, not up to the mark according to me. We wanted to repeat the CT scans at our center according to our protocol, because I told you the subtraction films are very critical. The axial X-rays are critical. Both were not available. But to save time, I would say that whenever I see a calcar fragment here, which is coming from the head fragment, like Hemant suggested, the Hurtle's criteria, this looked like a 2.5 centimeters. So I got excited. I said, this is a good calcar fragment. Prognosis is excellent. We should post him for a lock plate. And my assistants took him in. We went and operated him. And as I went in to put in the plate, we realized that the head was connected to the shaft and it was peculiar, but it was extremely osteoporotic. And there was a large lesser tuberosity fragment, So this was, we realized the posterior fracture dislocation. And so I said this lesser tuberosity fragment has to go back in. But we put in 2 cc screws, like what you saw for the previous case from Prashant, that we thought we'll do the McLaughlin type of fixation. And the 2 cc screws just backed off right on table. There was absolutely no hold. It was osteoporotic and a hollow head completely. So I said, that's fine. We'll just suture this with a number 5 ethibond. And we sutured everything, we reduced the head back in position. And we said, we've achieved this. We'll just leave it there. We were smart. We thought we were smart. And so we keep an external rotation brace. So we immediately apply. And that's a very clever thing to do with the posterior fracture dislocation patients, because this will maintain them inside the joint. You put them back in a sling, they will dislocate posteriorly. And then follow-up is difficult. It brings you back to earth. The first post-op X-ray looked good. And this second day, we get a fresh X-ray done, and the whole fragment had collapsed down. And we understood that this bone quality is absolutely pathetic. And so we went in and I sat with him and counseled him. And I told him, see, son, this is not looking good. I need to go back in again. But I'm not sure why this happened. So we dug in, and I was looking for a history of drug intake, whether he was cocaine or some addict or something. And then he revealed to me that he was an epileptic for the last 30 years, and he's been on medicines on epilepsy. And epileptic patients have a lot of severe osteoporosis. He hid the information because he thought that the Mediclaim will not go through and it will affect it. And having said that, it doesn't absolve me of my responsibility, but I realized that this was not going good. So we posted him directly on the third day, on the Tuesday. And because his quality of bone was poor, we kept a hemi on the backside. But he had very typically twice told me that as far as possible, don't do a shoulder replacement, because some of his doctor relative had told him that at such a young age, you must not do one. So I chose an in-between approach. And so this is a staple that retains the head. This is the stem part. So they are modular. So this is the reamer for the stem. So you put in a stem and you put in a staple and then made them together to get something like this, which is called as a just unique. So we had an intramedullary fixation, which was absolutely what was required, ideal for an osteoporotic bone. We also respected his request that try not to do a hemiarthroplasty. So we have preserved his head, and we seem to have got away reasonably well on AP and lateral X-rays. So this was done immediately on intra. What is very important is you must understand posterior instability is rare, and that's why complicated. So not to be taken lightly. Even in expert hands, it can fail. And once you've done it, it's important to suture back the anterior sleeve, posterior sleeve, and get a watertight, complete parachute closure, because the soft tissue will give him function. That is very important. In this case, the lateral X-ray should have been done first. Subtracted CT scan view should have been done. Our ER brace should have come on time, and then we would have done reasonably well. So this is an X-ray after 8 weeks. He's healed well. Unfortunately, because of the lockdown, he's not been able to come down. But his rehab is going on. He's done reasonably well. Again, a very peculiar fracture. Even after so much experience, I can't confirm and say with conviction that I understand all proximal humerus fractures. So they can get very dicey. Thank you. Thank you for your patience.
Thank you, sir. Very nicely elaborated, and we are lucky enough that the last case also could fit in. It was quite a beautiful session. I think everybody is going home with enhanced knowledge. I think Rakesh Bhargav sir is with us, very senior professor, ex-head of the department, SMS, and we have all been his students. Would you like to comment, sir? Would you like to add on something, sir?
Yeah, I would. Thank you, Rahul. I will begin with a very small observation on the posterior dislocation. When I was a resident, Dr. P.K. Sethi told me that when you look at an AP view of a shoulder, there is what is known as a crescent sign. The part of the head should cover the glenoid like a crescent. If it is not there, then think in terms of posterior dislocation, go for an axial view. So this is the very basic. Go for an axial view if the crescent sign is not there. I fully agree with Ashish on this, that the philos, is not the be-all and end-all of upper end humerus fractures. This is what it started as when the Philos was introduced, and everyone was doing a Philos for any kind of upper end humerus fractures. The result was that the plate was walking out, the screws were walking out, it fell into disrepute. And AO went and modified its implant, modified its instrumentation. And now, as Ashish has pointed out, it still has a failure rate of 25 to 30%. So be very careful in your selection of cases. Be very careful in doing that. Do not play around with the Philos. It's not a be-all and end-all. The third thing I would like to make an observation is about what Hemant did for a hemiarthroplasty. You see, there was a time when we were just ramming in uncemented knees prosthesis where there was a grossly comminuted upper end humerus fracture. Times have changed. The prosthesis has changed, and therefore the results have changed. But still, if you can preserve the upper end of the humerus, if you can preserve the head, preserve it instead of doing a shoulder arthroplasty. I'm putting this question to all the panelists. How many cases of avascular necrosis of humerus have you seen in absolute numbers and a percentage of your practice? How many? It's not common. It's not like the avian of the hip. So stop being scared about the avian and of the shoulder and sacrificing the head. Preserve it as much as possible. I think this has been a very nice session. There was so much which I have learned. Ashish, what he has shown as an intermediate between replacement and internal fixation. That's a beautiful idea, and we do get such cases. And I think I'm really privileged and honored to be here, and honored in the sense that I have learned. I'm more than 70 now. I have learned something, and I love it. Thank you.
Thank you, sir. Thank you.
Thank you, sir.
Just to summarize, let the session be end. Dr. Ashish, kindly summarize the session, then we can say goodbye and join as delegates on the other session.
Yes. Thank you, Rahul, Dr. Bhargava, and all my colleagues here. I think this session was very important because it has presented diversity of proximal humerus fixations, and right from junior to senior hands, we've done exactly what was right for us. And this is very important for the audience because they are going to take back a lot of this. In a small time of 1 hour, we have covered and managed to cover all the important facts. Keep this up. It is important that we keep our minds open. We must understand that we are not God, and we can all make mistakes, but we should minimize them and try to do the best thing the first time. My basic plea to all the delegates here is, please, in a shoulder, do lateral x-rays. It's very important. You do them for ankle and knee and hips. Why don't you do them for the shoulders? You'll ensure that these blunders don't happen. And if you can, get CT scans done without hesitation. Keep it up, all you young guys, surgeons. My blessings are with you. And I wish ROSACON every success that it should have. Thank you, Rahul.
Thank you. Thank you, Dr. Ashish.
Thank you, sir.